Defining Myopia Management, Clinical Insight and Real-World Impact of Hot Lens Technology. To chair the session, I would like to invite Dr. Radhika Sachdev, Dr. Rakesh Malhotra sir, Dr. Vikas Khatri, Dr. Radhika, and I would like to invite our speaker, Dr. Kunal Srivastav. Dr. Kunal Srivastav is a Director, Medical and Professional Affairs. He is affiliated with SLR India Private Limited, and he is MBBS, MD, MBA. Please welcome Dr. Kunal.
Thank you everyone, and yes, I'm honored and humbled to be given this dash over here. I thank to IAP West and Westcon that we have really different topics over here. I think the whole theme that you bring together everything so that whenever a child is there, every pediatrician, they will understand that which way it could go, and even the way agenda has been arranged, that there's so much of crossover, so many different faculties coming in and bringing things together. Now, what I'm going to talk about is, yes, we are going to look at kids with dreams, those who become adults with vision. But what is really important to know, and this is that 50% of the population is going to be myopic by 2050, and this number is huge. We all know during our all the days, PG, UG, PG, the only thing that we have learnt about myopia is that you give glasses. If something happens, maybe after 18 years, we'll go for LASIK or maybe a smile and everything will be corrected. You'll get rid of the glasses. Exactly, that is how we all have seen myopia until a few years back, when people actually started to look at it from the point of view that what are the complications that it could cause and whether we can do anything about it or not. Well, numbers are grim, whether you look at whichever data point you look at, and if you look at the projection by 2050, things are going to get much worse. Be it high myopia, be it myopia alone, and so the complications of it. Across globe, it's rising. Across globe, wherever we see, and it is going to hit 50% almost across globe. Even in East Asia, it's going to go up to around 65%. And that is huge. We are talking about the whole population, and out of that 65% having myopia. More than 50% having myopia. So this is going to be the next maybe cardiovascular disease or hypertension or diabetes which is going to happen. And that's why it is important, because this is going to impact children. I'm not going to get into the very depth of as to what happens, but we all know when the child is born, he is hyperopic, and within some years of time, the eyes grows normally and axial length increases and it becomes normal or emmetropic, let's say by 6 years, 7 years. What happens in myopia is, eye is elongating even more than it should be. And this is what is causing all the problems. It's not only about what power you are wearing, whether it is -1, -2, no. It is everything that is happening is because axial length is increasing. Once your axial length increase, and the problem is, if you look at the child, they might not be able to tell you, right? This is what we have been discussing since morning. If a child who is developing myopia, they might not be able to communicate it to you. For them, okay, this is how the world is. Maybe this is how blurred things are supposed to be. They might not even look at the blackboard. where 80% of their education is going to happen what they see. And this is where the whole problem starts. But usually they might have some complaints, maybe blurry, or maybe they'll talk about that sit closer to the TV. They'll go very close to the screen whenever there's anything, or maybe headache, something. There might be some hint over there. And this is the reality. Even today, 1 out of 3 children, they can't actually see the blackboard. And we think they are not performing well because they are not studying well, which is not the case. And there are several factors that's going to impact whether child is going to get myopia or not. Most important is family history, parental history, then ethnicity, then there are optical factors, near work, and time spent outdoor. Now, if a single parent has myopia, then the risk of having myopia is 2 times. If both the parents have myopia, the risk increases 5 times. Now, we are talking in times and not in percentage. So, this becomes important. Ethnicity, unfortunately, being Asians, we have been with the set of genes that wherever we see, whatever is happening is going to happen much faster, much worse with us, with Asian as compared to Caucasian, and it is quite similar in terms of myopia also. Optical factor, if I have to explain, whenever you correct myopia with negative lenses, what happens is some of the light starts getting focused behind the eye, and that is a very strong signal for eyes to grow. So that means if we are correcting myopia with single vision lenses, the normal what has been given, it is actually a cue for increasing myopia. And that's the worst part of it. Usually, earlier people used to think that maybe we can undercorrect and that would help. Now the studies have told us, even if you undercorrect it, then again it's a big cue for axial length to increase. So what to do? Right? Near work activities increases risk of myopia as well as progression of myopia. So if your child is looking at the screen which is less than 30 centimeter or at least elbow length, now this is going to increase the risk of myopia and even myopia progression. Near work has been condemned in more ways than other, but now what we see today, every child in a school, they are supposed to look at the screen. Now most of the courses is on screen. What to do about it? Outdoor time has shown that it could prevent the onset of myopia, but it has not major role in slowing down the progression of myopia. But yes, this is again a kind of thing that at least 2 hours child should be outside, bright, if we can get garden where they can see far and it's greenery, that is going to prevent the onset of myopia. But if myopia has already occurred, it has not major role in slowing down the progression. So why we want to stop this axial length growth? Now again, this is very serious because it causes macular degeneration, retinal detachment, cataract, glaucoma. And just look at the numbers. If your power is between -6 to -9, the risk is 40.6 times. Again, not percentage, it's times. When we talk about CVD, even 2 times is huge number. Here we are talking about something around 40 times. And you can see, as low, even if your power is -1, still you have lifelong risk of these complications going from somewhere around 1.65 times to going up to 3.1 times as compared to someone who is emmetropic, who doesn't have myopia. When we talk about correction and management, so usually what we all have seen that earlier we used to be happy with correction, right? Oh, you have got some power, use minus lenses. Maybe after 3 months you go, power has increased, you go up until you are 18, maybe power is increasing, maybe now it's the time to let's go for LASIK. That used to be the way. But again, for LASIK, you need some corneal thickness, right? You mostly -6 or -8, not beyond that you can go with LASIK. And then again, it's more like palliative because your axial length has increased, so the risk that was going to be there is already there. All you are doing is removing glasses. Myopia correction is something which is even under correction and correction. Only single vision lens, no. They have to be on something that could slow down the progression, and that is where myopia management comes into play. And why it works? Because if you can just stop one diopter progression, you can reduce so much of risk by huge numbers. Just one diopter, if you're using some management. Now from SLR, yes, we came up with a very game-changing spectacles. These are Stellest. Now, it comes with a lens which has got internal design, which has got highly aspherical lenslet, that is 1021 lenslets are there. I hope if I can play. Okay, so how can I play this? So usually what happens whenever the rays are falling, if myopia, it is falling in front, you use a lens and things go beyond your retina, and that is when eye starts to grow, the axial length starts increasing. Now when you use these special lenses, as I said, it has got 1021 lenslets, it changes something. It changes the way light is getting focused, which was earlier falling behind the eye. Whenever you are using a negative lens, it brings it in a volume, type of a volume in front of retina. And what we have seen is that this signaling, where light is falling in front of retina, it acts as a stop signal for the axial length to grow. And that is what we see with these lenses, helping in slowing down the progression. And that's what we say, that if we can only prevent the progression from even one diopter, we are going to do so much of good. One thing that comes to our mind, okay, while well said, but do we have any clinical trials, any settings that has proven it? Yes, we have done clinical trial. It has gone even, it's currently in 7th year now, published 6-year data. Now, if you see, it helps to reduce the elongation of eye by 60% within 2 years of time. Even there were 28% of children whose eye didn't even grow, those who are myopic, for the whole 1 year. By the end of 6 years, we are able to prevent almost 2 diopters of growth and around 0.81 mm of axial length. So 0.3 mm equals to around 1 diopter. So if your axial length increased by 0.3 mm, it is usually 1 diopter. So almost over there. And this 0.81 is something which is really important, because now you are slowing down the progression of myopia. And this is where your chances of complications can come down. Not only this, very recently, just this September, we got the marketing authorization by FDA for these lenses, and these are the first and only spectacle lenses that have been approved for slowing down the progression of myopia in children. So, important principle which is there, which I think is more useful for all of you over here, is we have to communicate this to the parents, right? We have to communicate them that why this is important. It's not only about correction, now it has become about what it could be. Today, by using these glasses, maybe your frequency of power changes will reduce. So instead of doing it every 3 months or 6 months, you might have to do it after 1 year or 2 years. But more important is, in later phase of life, we are preventing the complication and the risk of blindness that could happen. Even today, as we know, that precision jobs are there with so much screen times, and that is where it becomes even more important. Now only I think armed forces, they check for axial length, because people do use LASIK and go for armed forces, right? It's not only about power, because they know if you recruit someone who is going to get blind or maybe a retinal detachment after some time, they might not take them. And this is where the world is moving out to be. The best option is to prescribe optical treatment first. If it's still progressing by, let's say, more than 0.5 diopters or 1.25, you can also add atropine to it. And most important is start as early as possible, because even at -1 diopter, there is still risk of retinal detachment, glaucoma, and everything. It's still there. So every child's sight is precious, and this is something that we all can do and take care of if we really want to prevent. And the numbers that we see, more than 50% in 2050, maybe we don't want to go there. We don't want a nation of children, those who have poor eyesight, and not only that, with more of complications. So with this, I think I'll end. Thank you for patient listening.
I think it's been really eye-opening to most of us. We are not aware of such a thing that happens in ophthalmology as far as children are concerned. And may I know what would be the cost like to use this?
So these lenses, pair of these lenses, they are around 16,000. And there will be few offers. I think our sales team would be better to tell. So it falls around 13 to 16,000. But the most important thing is that to mention it to the parents, because sometimes parents, when they reach to pediatric ophthalmologist and their power has increased, they said, why not my pediatrician told me that this could happen, or this is a dangerous thing that is happening, or there's something that we can do about it to reduce or maybe slow down this progression.
And till what age group can we use this?
So as per the latest guidance, French Ophthalmic Society, they have given that from 4 years to 20 years. Earlier we used to see a myopia stops growing around 15, 16 years. But now you would see it's going even beyond 21, 22 years. Maybe the screen and the everything. But yes, up to 4 years to 20 years, you can use it. And it is quite convenient. It's non-invasive. It's just anyways, if you use atropine also, then the child has to wear his spectacles. So non-invasive and FDA approved. So that's a good combination.
It was a very interesting session. Thank you so much, Dr. Kunal.
Thank you. Thank you.
Topic is a shy child, psychiatric perspective. To chair the session, I would like to invite Dr. Surinder Singh Bisht. Is it there? Dr. Bisht is not here. Dr. Raman Kundra. Dr. Raman Kundra is a medical superintendent at Shankar Hospital, and Dr. Mridu Sehgal. She's the owner of Neo Sehgal Hospital, and Dr. A.C. Mishra. Sir is a consultant pediatrician at Dwarka. And I would like to invite our speaker, Dr. Rajiv Sharma. Dr. Rajiv Sharma is a consultant and founder and director of the Beautiful Mind Clinic at Janarpuri. So please welcome Dr. Rajiv.
Hand mic, please. Have a look.
Dr. Rajiv Sharma is a known psychiatrist in West Delhi. I is a very good friend of mine, having a very beautiful mind, working in a beautiful mind clinic.
Just 2 months back, I listened to his other aspect of mind, the business mind.
Thank you.
The whole day I listened to you that day. I was in
It's a
South Delhi. Yeah.
Okay. So, अच्छा टाइम स्टार्ट सर कोई नहीं
अभी
मैं
शुरू कर
स्टार्ट
सकते
कर देता हूँ
You can please start, huh?
थैंक यू सो मैं हिंदी में बोलूँगा आई होप एवरीबडी कैन अंडरस्टैंड हिंदी आई फील मोर कंफर्टेबल जोक्स भी थोड़े बेटर है सो शाई चाइल्ड में बच्चा शर्माता है ये कंप्लेंट काफ़ी पेरेंट्स करते हैं जस्ट लाइक फीवर में इट कैन बी डेंगू इट कैन बी कैंसर और इट कैन बी कॉमन कोल्ड और इट कैन बी कोविड सिमिलरली शाइनेस इज जस्ट ए सिम्टम जो डिफरेंट डायग्नोसिस में वेरिएड काइंड ऑफ प्रेजेंटेशन पॉसिबल है इवन इंटरेस्टिंग बात तो ये है कई बार आजकल पेरेंट्स के बच्चे कम हैं कंपैरेटिवली जितने पहले होते थे तो कई बार वो पेरेंट्स बच्चों को लेके आते हैं और बच्चे नॉर्मल होते हैं उनको लगता है हम बात नहीं कर पाए तो ये ज़िंदगी में कुछ आगे ज़्यादा बढ़ जाएं तो दे आर एक्चुअली नॉट शाई बट द पेरेंट्स एक्सपेक्टेशंस आर हाई सो दैट इज़ ऑल्सो वेरी इंपॉर्टेंट टू अंडरस्टैंड कि साइकेट्री में कई बार डायग्नोसिस उसका नहीं होता है जो आता है उसका होता है जो लेके आता है सो इट हैपन्स विद हस्बैंड एंड वाइफ ऑल्सो mother-in-law and daughter-in-law also so it happens with kids also so as a psychiatrist or a psychologist we should be open-minded कि जिसकी हम बात सुन रहे हैं उसकी बजाय हमें किसी और की बात भी सुननी पड़े शायद और उसको इलाज की ज़रूरत हो और ऐसा बहुत बार हुआ है क्लिनिक में सो दैट इज़ वन ऑफ द इम्पॉर्टेंट थिंग आई वुड लाइक टू शेयर विद यू टाइम लिमिटेड है तो आई वोंट गो इनटू डिटेल बट जो ये इन्फेंट टोडलर प्री स्कूलर स्कूल एज और एडोलेसेंट का जो एज ग्रुप है 0 to 1, 1 to 3, 3 to 5, 5 to 6 to 12, and more than 12 beautifully correlates to Sigmund Freud psychosexual stages of development जिसमें oral, anal, phallic, latency and genital है. They are very interesting, but the time would not allow, so I would miss that. But जो psychosocial stages of development है Erik Erikson की, they are my favorite, and which apply to us also. जैसे like right now I am 51, so I am in stage of जनरेटिविटी वर्सेस स्टैग्नेशन मतलब या जनरेटिविटी वर्सेस स्टैग्नेशन का मतलब है या तो आपको चिंता हो जाएगी कि आप बुढ़े हो रहे हैं अब पता नहीं जो भी सर्जरी कराएं या मंजारो लगाएं या अपनी ज़िंदगी बचाएं या फिर यू नो दैट टाइम हैज़ कम नाउ यू इट्स टाइम टू गिव बैक चाहे वो अपने बच्चों को प्रॉपर्टी दें चाहे एजुकेशन दें चाहे कुछ भी करें आप जो भी आपका मन करता है सो उन्हीं की ये स्टेजेस हैं बट दे आर रिस्ट्रिक्टेड हेयर टू 12 ईयर्स प्लस तक तो ट्रस्ट वर्सेस मिसट्रस्ट का मतलब है जैसे रिसर्च में बोलते हैं कि बच्चे को प्यार मिलेगा तो आगे जाके वो सिक्योर होगा दैट इज़ ट्रू बहुत सारी रिसर्च में होता है कि प्ले स्कूल में डाल देते हैं पेरेंट्स दैट इज़ अ डिफरेंट थिंग बट अगर घर में कोई नहीं है तो बेटर है कि वो प्ले स्कूल में रहे बट अगर बच्चे को प्यार मिल पाएगा तो उसका फ़ायदा होगा और प्रैक्टिकली मैंने अपनी बेटी को प्ले स्कूल नहीं भेजा था बिकॉज ऑफ दिस रीज़न ओनली बिकॉज ऑफ द बैकग्राउंड ऑफ साइकेट्री कि शी रिमेन्स एट होम ओनली जब स्कूल जाना होगा तभी डायरेक्टली जाएंगे तो उससे भी साइकोलॉजिकली बहुत फ़ायदा होता है बिकॉज इफ देयर इज ए ट्रॉमेटिक मेमोरीज व्हेन द चाइल्ड इज़ वेरी यंग 2 to 3 5 ईयर्स में तो उस टाइम प्रूनिंग होती है ब्रेन की सर्किट्स की तो उस टाइम अगर एंग्जाइटी या स्ट्रेस ज़्यादा रहता है तो बाद में आने वाली होल लाइफ में दे विल रिस्पॉन्ड एट ए हायर लेवल जैसे जिनका सेक्शुअल अब्यूज़ होता है फिजिकल अब्यूज़ होता है डिफिकल्ट फैमिलीज होती हैं दे हैव मोर टेंडेंसी ऑफ सेक्शुअलिटी अटेंशन सीकिंग बिहेवियर borderline personalities and other issues also that is also important second aspect है autonomy versus shame बच्चा चलने लग जाता है they become slightly more confident और अगर somebody is I'm just simplifying over simplifying कि somebody is handicapped may self doubt and may feel something is missing on me second is initiative versus guilt कि बच्चा जो है वो आगे जाने लगा है बाकी बच्चों से बात करने लगा है पेरेंट्स उसकी तारीफ़ कर रहे हैं या नहीं कर रहे हैं ही इज़ 3 to 5 years of age और पेरेंट्स ही उनके भगवान होते हैं 5 साल तक बट अगर नहीं तो कई बार पेरेंट्स ओवर एक्सपेक्टेशन से भी बच्चे को गिल्ट में डाल सकते हैं उसके बाद है नेक्स्ट स्टेज है इंडस्ट्री वर्सेस इन्फीरियरिटी अब पेरेंट्स के बजाय वो दुनिया स्कूल की नज़र से देखता है बिकॉज वो 6 से 12 ईयर्स का है वो फर्स्ट स्टैंडर्ड से 6th स्टैंडर्ड तक जाएगा तो उसमें क्या होगा कि टीचर्स और उसके फ्रेंड्स इंपॉर्टेंट हो जाएंगे बट मेनली टीचर्स तो सोशल एंग्जाइटी OCD ये सारी चीज़ें जो सिगमंड फ्रॉइड के कॉन्सेप्ट हैं और साइकोलॉजी के कॉन्सेप्ट हैं यहाँ पे कहीं बिलोंग करती हैं देन देयर इज आइडेंटिटी एंड रोल कन्फ्यूजन जब माँ बाप की औकात भी खत्म हो जाती है और टीचर्स की भी इट्स वेरी डिफिकल्ट टू मैनेज ए क्लास ऑफ 11th and 12th स्टैंडर्ड टीचर्स को नई फीमेल टीचर्स को डर लगता है क्लास में जाते हुए और मैंने खुद भी देखा हम खुद भी चक्कर लगाते थे जो नई टीचर्स आती थी फिर मैं बड़ा दुख होता था अगर उसकी शादी हो जाती थी तो सो ठीक है So we'll start with the cases जो shy child की तरह present कर सकते हैं. 18 year old, I won't go into detail, already आपको पता है, but I want to give a psychiatric perspective कि कितने सारे possible diagnoses हैं with this is just a single word of shyness. Because जैसे depression है, fever है, लोग कई words को wrongly use करते हैं because they are socially accepted. तो shyness जो है वो socially accepted word है, तो they will present like that, but there can be different pictures. So उससे कोई फ़ायदा नहीं है कि पेरेंट ने क्या कहा, उसके पीछे क्या हो सकता है और एज ग्रुप कौन सा है वो ज़्यादा मैटर करता है. बच्चा अगर छोटा है तो उसमें अगर आई टू आई कॉन्टैक्ट नहीं हो रहा है, ही इज़ नॉट एबल टू पॉइंट एट थिंग्स, वो अपने आप में गुम रहता है और वो अपने नाम पे भी रिस्पॉन्ड नहीं करता है एंड इंटरेक्ट, वो अपने पीडियाट्रिशियन से भी इंटरेक्ट नहीं करता है, तो समथिंग इज़ मिसिंग ऑफ. तो द फर्स्ट पॉसिबिलिटी दैट शुड कम टू द माइंड इज ऑटिज्म स्पेक्ट्रम डिसऑर्डर. द चाइल्ड इज यंग एंड इट स्टार्ट विद सोशल स्माइल ओनली. माइलस्टोन्स तो आपको मेरे से ज़्यादा अच्छे से ध्यान होंगे कंपेयर टू मी. सो इट स्टार्ट विद सोशल स्माइल एंड स्ट्रेंजर एंग्जाइटी एब्सेंट होगी, किसी की गोद में चला जाता है और नेम पे रिस्पॉन्ड नहीं कर रहा है, खुद में गुम है, पंखे को देखता रहता है. तो दैट इज़ गुड इनफ कि एमचैट वगैरह करके देखें. 18 मंथ्स का ज़्यादा हो जाएगा तो डायग्नोसिस विल बी slightly more stable, but autism is something which is not very difficult to diagnose, but it is very difficult for the family to accept. Second है 2 साल का बच्चा है, he is not walking independently, minimal babbling है, limited eye contact, responds, rarely responds, fine motor में भी problem है थोड़ी सी, and little social interaction है, struggle करता है simple instructions में, क्योंकि जब 2 साल का बच्चा हो जाता है तो बच्चे terrible twos होते हैं. मम्मी जो है 2 साल में बहुत परेशान हो जाती है बिकॉज अब बच्चा जो है उससे इंडिपेंडेंट हो चुका है, वो माँ की गोद में नहीं रहना चाहता, वो दुनिया को एक्सप्लोर करना चाहता है. कई सारी फीमेल्स तो 3rd ईयर में दोबारा प्रेगनेंसी प्लान करती है बिकॉज उनको दोबारा बच्चा चाहिए जो उनकी बात सुने, क्योंकि पति तो सुनता है बट बच्चा नहीं सुनता 2 साल का. ठीक है. सो दिस इज नोन एज ग्लोबल डेवलपमेंटल डिले. इंटरेस्टिंग चीज़ ये है कि हम 5 साल से पहले इंटेलेक्चुअल डिसेबिलिटी वर्ड यूज़ नहीं करते बिकॉज काफ़ी सारे बच्चे नॉर्मल हो जाएं, हो सकता है कुछ की डिसेबिलिटी कंटिन्यूड रहे, तो वी कैन से इंटेलेक्चुअल और IQ इज़ लो ओनली आफ्टर 5 years बिकॉज असेसमेंट के बाद वो स्टेबल रहेगा. इस एज में हो सकता है इट कैन वेरी ए लॉट. सो 2 या मोर एरियाज में कॉग्निटिव, फाइन मोटर, लैंग्वेज, जो भी एरियाज हैं उनमें अगर डिले आ रहा है तो फर्स्ट पॉसिबिलिटी विल बी ग्लोबल डेवलपमेंटल डिले. देन देयर इज अ 4-year चाइल्ड. एवरी मॉर्निंग जब उसको स्कूल जाना होता है तो वो क्लिंगिंग करती है, रोती है, उसको स्कूल नहीं जाना होता. कई लोग स्कूल के बाहर खड़े रहते हैं, क्लिनिक में पेशेंट्स आते हैं, मैं डॉक्टर सारिका देखते हैं तो स्कूल के अंदर ही नहीं घुसते या स्कूल से स्पेशल परमिशन लेनी पड़ती है. और क्रिश्चियन स्कूल हो तो वो तो घास नहीं डालते हैं, बट इंडियन वाले डाल देते हैं कि आप रिसेप्शन पे बैठ जाओ, बच्चा आके चेक करेगा आपको. सारे बच्चे तो ऐसा नहीं करते, बट जो लोग बच्चे करते हैं उसको सेपरेशन एंग्जाइटी बोलेंगे. दे आर परफेक्टली ओके. और कई बार ऐसे बच्चे होते हैं जो माँ बाप को फ़ोन कर करके दुखी कर देते हैं कि पापा ने 7:30 बजे घर आना है या मम्मी बाहर गई है और वो वापस नहीं आई, तो वो फ़ोन ही करते रहेंगे. एक बार तो मेरा बेटे ने जब नया नया फ़ोन करना सीखा था, उसको सेपरेशन एंग्जाइटी तो नहीं थी, बट उसने फ़ोन किया, उस चक्कर में एक बाइक वाली ठुक गया था मुझसे. तो इट इज़ वेरी इंपॉर्टेंट टू अंडरस्टैंड कि इम्प्लीकेशन बहुत सारे हो सकते हैं. तो उसको डांट पड़ी थी उस दिन के, आगे से फ़ोन किया तो उसको छोड़ूंगा नहीं मैं, तो चोट नहीं लगी, अच्छा हुआ उस बंदे को. सो दिस इज़ व्हाट इज़ नोन एज सेपरेशन एंग्जाइटी. तो बच्चे को स्ट्रेंजर एंग्जाइटी 9 मंथ से लेके 3 years तक तो नॉर्मल है, बट 3 years के बाद बच्चे दुनिया एक्सप्लोर करना सीखते हैं. मुझे आज भी याद है जब मैं एम्स में PG कर रहा था तो हम अंसल प्लाजा गए थे, तो मेरी बेटी दूर जाती थी, फिर वो टेढ़ी सी आंख से देखती थी कि माँ बाप हैं, फिर पास आती थी, फिर दूर जाती थी. तो एक्चुअली दे आर चेकिंग द बाउंड्रीज. जैसे कोई रस्सी है, जैसे कुत्ते को आपने लीश बांध रखी होती है, कि वो टेस्ट कर रहा है कि वो कितनी दूर तक इंडिपेंडेंटली मैनेज कर सकता है. एंड दैट टाइम आई वॉज डूइंग साइकेट्री, तो इट वॉज वेरी इंटरेस्टिंग टू सी द सेम developmental stages in my own child. So this is what. Then there is Ananya, this is the happening name. 7 साल की लड़की है जो sudden behavior change. Whenever there is a sudden behavior change, there is some event in the life. Whether it is sexual abuse, whether it is physical abuse, whether it is bullying, whether it is a post-traumatic stress disorder, or anything which has happened significantly. Sudden grades अगर down होते हैं तो इसका मतलब कुछ ना कुछ तो हुआ होगा जो पेरेंट्स को पता है या नहीं पता है. और सेक्सुअल अब्यूज़ की कोई एज नहीं होती. इट कैन हैपन टू ए 6 months चाइल्ड ऑल्सो, एंड इट कैन हैपन टू ए 60 और 80-year-old फीमेल ऑल्सो, एंड इवन मेल्स एंड फीमेल्स में भी कोई बहुत ज़्यादा डिफरेंस नहीं है. और क्लिनिकल रिसर्च में जो मैंने देखा है, पेरेंट्स अक्सर, सो इट इज़ वेरी इंपॉर्टेंट टू हैव दैट काइंड ऑफ माइंड सेट. सो दैट इज सेक्सुअल अब्यूज। जो सडन कभी भी चेंज आता है और बच्चा सेक्स की बातें करने लगे या किस या उस तरह की, तो इट इज़ अ वेरी स्ट्रॉन्ग इंडिकेटर समथिंग रॉन्ग इज हैपनिंग, एंड इट इज हैपनिंग विद समबडी whom you trust. तो देन नेक्स्ट इज somebody is quiet and प्रॉब्लम आता है उसको क्रिकेट खेलने में उसको पसंद नहीं आ रहा, नॉट पार्टिसिपेटिंग। जो छोटा बच्चा है उनमें फिजिकल सिम्टम्स ज़्यादा होते हैं रादर देन साइकोलॉजिकल, बिकॉज उनकी अभी वोकैबुलरी इतनी डेवलप नहीं होती। खैर नई जनरेशन के लिए बोलना मुश्किल है थोड़ा सा, हमारे जैसे लोगों के लिए ज़्यादा इंपॉर्टेंट है ये। सो दे माइट बी हैविंग जस्ट सोशल एंग्जाइटी। जिन लोगों को सिलेक्टिव म्यूटिज्म होता है या सेपरेशन एंग्जाइटी होती है, उनके चांसेस ज़्यादा हैं कि ओवर ए पीरियड ऑफ टाइम इट विल डेवलप इनटू सोशल एंग्जाइटी, नॉट एवरीवन but majority of them. Then there is another child who is for last 8 months he is withdrawn behavior, avoiding social interaction, staying at home, reluctant to attend his school. तो मम्मी डैडी को लगता है ये लेजीनेस है। हो सकता है कि उसके जो क्लासमेट्स हैं उसको बुली कर रहे हो उसके मोटापे की वजह से, या उसको कोई टीचर कई बार हरास कर रही हो जिसकी वजह से वो परेशान हो रहा है। सो दिस इज़ वेरी वेरी इंपॉर्टेंट टू अंडरस्टैंड। और अक्सर बच्चे अपने पेरेंट्स के साथ शेयर नहीं करते हैं, जो मैंने प्रैक्टिकली देखा है। वो अपनी भाई बहन के साथ कर लेते हैं, कजन्स के साथ कर लेते हैं, बिकॉज पेरेंट्स टेंड टू हैव सम काइंड ऑफ अथॉरिटी, सो दे हैव एन इशू। एंड बुलिंग इज समथिंग विच इज़ वेरी कॉमन, मूवीज़ में आपने देखा होगा, सो दैट इज़ इम्पॉर्टेंट। देन इज 8-year-old चाइल्ड स्ट्रगल्स विद रीडिंग राइटिंग। हमारी सोसाइटी में हम जो जितना मर्जी बात कर लें, नंबर्स बहुत मैटर करते हैं मिडिल क्लास में। बिजनेस फैमिलीज या पॉलिटिकल फैमिलीज हैं तो उनका फंडा अलग होगा। उसका फंडा कैसे अलग होगा? एक स्कूल में हम गए थे डॉक्टर सारिका के साथ प्रेजेंटेशन के लिए, तो वहाँ पे लड़के ने बदतमीज़ी की टीचर के साथ। तो आप क्या एक्सपेक्ट करेंगे कि पेरेंट बड़ा शर्मिंदा हो रहा होगा, नांगलो एरिया का था। तो कहता औरतों के साथ तो ऐसी बात करनी होती, तभी तो ये सीखेगा, कल को इसको भी नेता बनना है। सो दैट इज़ ओके फॉर दैट, बट बाकी मिडिल क्लास के लिए तो एजुकेशन बहुत मैटर करती है। तो अगर किसी बच्चे को स्पेसिफिक लर्निंग डिसेबिलिटी है, वो इंटेलिजेंट है बट वो मैथ्स में परफॉर्म नहीं कर पा रहा, उसका क्लासिकल एग्जाम्पल है, मेरा अपने बेटे को डिसकैलकुलिया है। तो 9th में जब मैंने उसका मैथ्स हटवाया था, तो मेरे फादर इन लॉ इंजीनियर, मेरे बापू इंजीनियर, मैं खुद मैथ्स का टॉपर, हमारे घर में हंगामा हो गया था। और सबसे बड़ा अजीब तो मुझे तब लगा जब मेरी वाइफ खुद 33 नंबर लाई थी 12th में मैथ्स में, वो भी कह रही थी मैथ्स मत हटवाओ, और मेरा बेटा भी कह रहा था मैथ्स मत हटवाओ, क्योंकि मैं पेंटिंग में बैठूंगा तो मेरे बच्चों मेरी इंसल्ट हो जाएगी, लड़कियाँ क्या बोलेंगी, लड़के क्या बोलेंगे। सिर्फ आई वॉज द ओनली वन हु वाज सपोर्टिंग, and even with the and at times even the child is not ready for that. That is important to understand. So this is
Dr. Rajiv.
Hanji.
Here, this side. So we are we all thoroughly enjoying your talk.
But
just
I
running
will
short
be
of
on
time.
Two and a half hours late.
Gaurav
नहीं
के
I will
बाद
do it
में-
in एक दो केसेस, एक दो मिनट बस, that's it.
He's like a true UCMS guy. Huh?
ठीक है। सो इसमें एक ये है कि बच्चा अगर कार एक्सीडेंट हो जाता है या सडन उसको नाइटमेयर्स आते हैं, सो नहीं पाता, तो पोस्ट ट्रॉमेटिक स्ट्रेस डिसऑर्डर की वजह से भी चेंजेस आ सकते हैं। मूव टू द डिप्रेशन पार्ट। सो दीज आर द डिसऑर्डर। इसमें ऑटिज्म है, ग्लोबल डेवलपमेंटल डिले है, सिलेक्टिव म्यूटिज्म है, सेपरेशन एंग्जाइटी है, सोशल एंग्जाइटी है। ADHD जब फीमेल्स में प्रेजेंट होता है, नॉर्मली इट इज़ इनअटेंशन, बिकॉज उसकी वजह से वो पढ़ नहीं पाती, फ्रेंड्स नहीं बन पाते, सो देयर कैन बी अ प्रॉब्लम। These are slightly different. हायर बच्चों में होंगे डिप्रेशन, लर्निंग डिसेबिलिटी, OCD, एंड दैट्स इट। सो इसमें जो रोल है वो सभी का इंपॉर्टेंट है। यूजली इट इज़ द टीचर्स हु डायग्नोज फर्स्ट, देन दे गो टू पीडियाट्रिशियन, देन कम अप विद द रोल। थैंक यू।
Thank you, Rajiv. Dr. Vidhu. Thanks. And I think that's a good spectrum of all, from expecting shyness, which a family believes, to real issues, which as pediatricians, these are the chapters we do not even read. I think these are, and we do not even think about those things. And you are always like that.
Request to you all, questions and answers can be taken separately because we are already very late.
Thank you, Dr. Rajiv, for interesting session. Thank you.
Dr. Layapi, he travelled all the way from Meerut to just be with us.
So now let's move on to our next topic. Pain abdomen in school-going children, a pediatric surgeon perspective. To chair the session, I would like to invite Dr. Prashant Jain. Dr. Prashant Jain is a Senior Director, Department of Pediatric Surgery and Pediatric Urology at BLK Max Super Specialty and Max Super Specialty, Dwarka. And Dr. Arihan Jain is also a consultant pediatric surgeon and pediatric urology specialist at Max Super Speciality Hospital, Dwarka. And to deliver a talk, I would like to invite Dr. T.K. Lama ma'am. She is a pediatric surgeon and HOD at Manipal Hospital, Dwarka. Thank you, ma'am.
हाँ जी कोई भी नहीं है यहाँ पर you'll be very short. So thank you very much for giving this opportunity to pediatric surgeons to participate in your मैं करूँ आप करो यहाँ तो मेरे पास आगे कैसे बढ़ेंगे एरो की interested because I was given this topic of pain abdomen in school going children. कौन सा press करना है ये वाला? So this is a topic which I'm sure you guys also have been talking about regularly. I've been talking about it regularly. I tend to teach this to the DNB students that come under pediatric surgery. And so I don't want to sound as if I'm a teaching person here. What I'd like to do is basically you can read the slide, you can listen to what I'm saying. I wanted to basically know what I would be covering if it is school-going children, which means that the non-verbal little neonates are out of the system, plus the toddlers and the infants, so then I don't have to talk about what could be troubling them. So this is what is the new directive. A child will start school only after completing 6 years. That means from 6 years to plus 12, that means 18. I'm correct? Mera bhi maths thoda my beautiful mind ki tarah nahi hai. So then this means till 18 years of age, provided they pass every year, they're all under us. Hopefully, because the WHO does say that, but you know, in the world outside that we live in, they start considering children beyond 12 and beyond 15 to be like adults, and then the adult surgeons and the adult, everybody takes over. So I would like to stake a claim by using this, that this is the group of children that come under us. ये pointer नहीं है इस पे आपके पास? कोई बात नहीं. So this is something that, you know, with all our boards, this is what is going to go forward, at least in Delhi. I don't know about the rest of the country. So it means that there may be a few people, few children who are in class 12, who may be about 19 and 20 also. And I think we will happily take them under us. So the background of abdominal pain is this is one of the most common non-specific symptoms. And I will like to put more stress on those that need surgical management. Surgical management need not necessarily mean that we will operate. It may mean that we may have a little bit of skills more to be able to let the child cross over to a better state of health. And then there are certain things which I would like to talk about and tell you what are the red flags which you also in your practice when you see, I'm sure you follow it. But for the youngsters who are trying to find their way out, you know, in children who are sometimes not able to tell you because they have stranger anxiety or they have a whole lot of shy children, then these are the things that I'd like to talk about. But the most important thing that I find missing today, and I would like to state again, is a thorough examination and a thorough history taking, because it's an evolving disease. So one of the pain, acute pain is what we'll be talking about. Chronic pain is not something that, you know, they usually will have had a diagnosis or they would have had some element of understanding between the parent and the child before they come to you. So what are the kinds of abdominal pain? Just as a description, one is visceral, which is a very dull, vague pain. The second is a parietal or a somatic pain, more intense, more focused, because this is the parietal area which is in trouble. And finally, it's the referred pain. I won't get into details about all the pathways, but basically the visceral pain, mota, wherever the origin organ is, that's where it will hurt. Especially for the intestines, the epigastrium is considered to be the foregut area. The periumbilical takes the midgut and the lower abdomen takes the hindgut. Now, this, you must understand, sometimes may be related with sweating, pallor, nausea, changes in heart rate and also blood pressure. The dermatome is where it is related. This is the dermatome in a small child. As you can see, everything is pretty much horizontal. Around the umbilicus is T10, thoracic 10. Below that, till the area of the supraumbilical area is T12. So if you can see this, that the whole T2 to T12 takes over the entire abdomen. And this is in a smaller child. You see the tummy is also small, everything is compressed. This is as a child gets older, you can see that elongates a little bit more, but the T10 remains to be the umbilical area, but you see the T10 is at a slightly higher area on the back. The area that you see that would be a person who would be probably a little bit taller than, 4 feet 5 feet, and those will be going into the adult zones where the dermatomes take a slight angle. Now parietal abdominal pain is more intense, sharp, it's intensified by movement, so people tend to not move that portion which is in pain. So children will be having this thing of being a little bit bent towards the site so as to not have an irritation because of that. So this occurs when there is an irritant that happens to the parietal abdomen, and this is also the pain that is reflected by the sensory nerves of the abdominal wall. And this is transmitted through the nerves, and this is when an inflamed organ comes in touch with the parietes. And this is the various causes. I can read it out, but most of it is related to peritonitis. Trauma is a very important thing because sometimes you may not have any external evidences. The child may not even tell you about the trauma. And of course, post-surgical pain or post-operative pain, history of any surgery done in the past. And pelvic pain by the same range of problems. So most of the times you can, very quickly think of the 4 quadrants. You know which organs, unless the patient has dextrocardia, you know the organs on the right side, left side, upper and lower. We are more specific. We go into the 9 quadrant system because that tells us an idea of localizing wherever the person or the child tells us about the pain or the parent gives us the history. Now pain, if you ask a child to point with a finger, they may be able to tell you, which may help you, but that usually does not happen in early stages. It doesn't happen in the newborns, it doesn't happen in the preschool, it doesn't happen in the primary. So this group of children is always going to need us to be more thorough, is the only word I can use for it. Okay? Because you see the child's hands covering the entire abdomen. Where is the pain? Everywhere. And then you have those children with special needs, and that is what I wanted to put focus on today, because we are forgetting that there is a very large number of population that are being seen by a lot of us who have special needs. They are non-verbal. This is an example of a child who came in with acute gastroenteritis. He was only 16 kgs at 11 years of age. And he was admitted under the pediatrician and they had been brought in after the parents had given him 2 courses of antibiotics over a period of 11 days, and they felt that the child was better. And they felt that, since the past 2 days, he's a little bit dull. Now, on abdominal examination, there was a very soft abdomen. They did get the usual routine investigations done. They got an ultrasound. Now, very interestingly, an ultrasound was reported, as you can see at the bottom end, is a right iliac fossa shows a non-compressible aperistaltic blind-ending tubular structure arising from the cecum with enlarged locoregional lymph nodes, likely inflamed appendix, mild ascites. But you see, this kid, when they examined him, he had a soft abdomen, non-tender, but his counts were 22,000, which is super duper high. His CRP was in the 200s. And please remember, he'd had this gastroenteritis for the past 2 weeks, so everybody was focused on that. When the intensivist went to examine this child, again, the right iliac fossa was normal. Why? Because the radiologist had given this report. This is a generic cut paste. So this is the time when you should have a referral to a pediatric surgeon or go downstairs, see the ultrasound yourself, because the next photograph is the call I get at 9:30 p.m. after a CT scan is done, and you can see very clearly that there is this lesion that is sitting out there. Now that is not the right iliac fossa, that is behind the colon. What you see on that is the coronal section. You can see the kidney on the right hand side. There is a very hyper-intense dye study, which is that of the upper colon, and you can see this hypo-intense area that is down below, and that is a ruptured retrocolate perforated appendix sitting in a child whose cecum is high. So yes, his right iliac fossa is normal, but the right hypochondrium, the central abdomen is tight and tense, and he is hypotonic because he's got congenital disorder of glycosylation. Yes, it is traumatic for me because I had to go read all that which I don't really need to read about, because this affects the child everywhere. Poor immune status, cardiovascular problems, neurological problems, developmental delay, hypotonia, anesthetic risks, a whole lot of studies that for 24 hours I was totally immersed in understanding what this disease was. I hadn't read about it maybe for the past 10 years or so. So this is important because wherever you see such children, these are the children that need urgent medical care, ICU care, and a whole array of things then we have to trigger off at 9:30 p.m. at night when the child has actually already been in the hospital for more than 36 hours. So these are the special needs that we need to look forward and take a quick decision and involve certain other departments as well. So the various causes, radiation of pain, referred pain, relieving, aggravating factors, these are all very academic. Associated symptoms are very important because sometimes they can confuse us and sometimes they can also make a wrong diagnosis. We can be traveling on a wrong path. But however, we need to understand that certain things are associated which may also be pointing towards a urinary system, because the abdomen tells us pain that is related to everything that is there in the abdominal cavity, in the retroperitoneum, and also in the spinal column. And the most important thing is now that I will talk to you about is, that goes backwards, dietary history. Very important in today's day and age where the children don't tell us what they eat, parents don't know what they are eating, parents are saying khana to dete hain, dete to ho, wo khate hain ki nahi, wo alag cheez hai. Then bowel and bladder habits are very important because the rising causes of abdominal pain, one of course is stress, second is gastritis, whatever you guys are seeing at a big broad base. But the second level, that is constipation, has its ramifications in having appendicolids or fecolids, and that gives rise to appendicitis, which is on the rise in our country today. So whole list of other things, because gallbladder disease causing cholecystitis and cholelithiasis is on the rise. Family history for all these things, hemolytic disease, we need to ask all those things. Physical examination, if you find that the child is lethargic, irritable, non-consolable, lying perfectly still and not moving his abdomen during respiration, please call the surgeons. This looks like a child who might go into an unstable septic area. So this is just routine stuff. I'm just going to tell you some interesting findings. You all know what the pain, tenderness, guarding appendicitis on the right side. Interestingly, if you touch the left side in a child with appendicitis, he may show you this sign called Roughsing's. Another one is Murphy's that can happen in cholecystitis. You touch the upper abdomen in the hypochondrium and make the child inspired, they may have pain. Cullen sign, Gray Turner sign is blood in the area of the flank, blood in the area of the umbilicus, occurs because of retroperitoneal hemorrhage for whatever the cause. Fox and Bryan signs similarly are telling you retroperitoneal hemorrhage coming down. Fox's sign over the thigh inguinal area. Bryan sign can be seen in the scrotum, especially in adrenal hemorrhage. And those are the things which I just thought you would like to know of, because you know most of everything. And auscultation is very important, and I find that a lot of people don't know how to pronounce this word. It's called borborygmus and borborygmi or rigmi. So it's basically those gurgling sounds that you can hear. If you hear too much of it, it means that maybe there's some obstruction. If you hear nothing of it and only a tinkle, that's also obstruction. And if you hear no sounds, that is also obstruction. So physical examination, please don't forget in boys to examine the genitalia. It is of doubt in the Western world whether you'd like to do a rectal examination, but in India, if you take permission from the parents, they do allow you to do it. You can make out the difference between a pelvic abscess and appendix in these cases. Medical legal cases, the pointing, right upper quadrant pancreatitis, medico-legal testicular torsion, medico-legal incarcerated hernia, ectopic pregnancy, ovarian torsion, intussusception. These are very, very vital for us that we should not miss this. And by age, if I go forward, most of this you would know. Don't forget that children who are non-verbal or not able to say things are sometimes naughty. They open, they eat batteries, they drink toxins, they have paracetamol that is left by somebody. Minoxidil of my friend was ingested by the son who's non-verbal autistic. So we have all these things. Abdominal trauma is something that they don't tell you about. They could be bullied in school, they could be having an accident. So we need to understand adolescents are a different game altogether. For them, girls, PCOS, ectopic pregnancy, pregnancy, please don't forget. Boys, testicular pain, please don't forget. And finally, coming down, relieving symptoms for our children. This is the red flags that I can tell you that you have for children. I've covered it, most of it in my talks. And finally, signs suggestive of acute abdomen, please call us. We'll help you. Thank you.
Thank you, Dr. Lama, for talking about pain abdomen in such detail. But one thing which I would like to add, your talk was more from a surgeon's point of view. From clinical practice, rather general pediatrics, most common cause these days we are finding is simple constipation because of lifestyle changes.
First the stress, sir. Exams ke pehle dekho.
And of course, functional abdominal pain is always there.
Yeah, thank you, everyone. Any questions? I'll take it outside.
Thank you, ma'am. Thank you a lot for giving very basic information about abdominal pain. And as you correctly said, history taking and clinical examination is very, very important. And it is very important that we should be doing a complete thorough examination. Do not forget that you should also examine the genitalia. As you correctly said, the most common reported case, medical legal cases reported in the Western countries is the patients who presented with abdominal pain and they have been diagnosed to have testicular torsion, which was missed because the child just presented with abdominal pain. So please do not forget about to examine the genitalia. I will have one question from you, and probably the audience can also get involved in it. Appendicitis. Now, there's been a lot of debate which has been going on for the conservative versus the surgical management of acute appendicitis. So I just wanted to know your comments that what you will suggest to our pediatricians.
Yes, because that's why I said I don't have to suggest anything, because most of the time the pediatrician is somebody that the family who they go to regularly, they trust. And antibiotics will decrease the inflammation, the infection, whatever, that first case that I showed you. However, if the primary cause is not taken care of, it's going to happen again. So go ahead, give the antibiotic, it'll rest for some time. Parents will get used to the idea ki ho sakta hai. Some people have an appendicitis and don't have it for like 15 years. Then they're adults and then they do whatever it is. Some people, this child came back to us in 11 days time with wrong diagnosis. And some of them are even worse. Some of them are like this. Can you see this? This is an appendix that they forgot about. And then this ruptured and it created this huge mess for this child. So these are various things that can happen. This is a kid who had pain in the testicle but was very shy, did not tell the family till the next morning. Next morning the family kind of said, okay, pain in the tummy, let us see what happens. By evening he said, no, I have pain down here. By the time they came to us, it was about 36 hours. We had to go in, we had to take this out because there is no alternative, we have to leave it. So, you know, the whole thing of, there is also a group of people who say, adult urologists who say, leave this behind. I still don't know whether I should leave this behind, and I will always leave it to the parents. I come out, I show them this picture. You can see that when I've cut the testes, there is no bleeding. So these days, my practice has changed quite dramatically. I believe in collaboration with both the pediatrician as well as the parents. I said, you tell me what you want me to do. I'm just a skilled technician. I will do whatever you want. Thank you.
Thank you.
Thank you. Thank you. Just to add a comment, there is a recent study in the Lancet being published, which is a multi-center trial on which comments as a randomized control trial in appendicitis, in acute uncomplicated appendicitis, antibiotic versus surgical management. So as per them also, they says that there is a failure rate of 20% in if we continue treating the child with similar symptoms with antibiotics. Because as per them also, the gold standard of treatment is to get it off earlier.
So as a surgeon, you always advise there is no role of any conservative management once you have made a diagnosis of acute appendicitis. That's the message. Thank you so much.
Thank you.
Thank you, Dr. Lama. Dr. Pankaj Goyal, he is a consultant pediatrician and he is attached with the Krishna Child Care Clinic, Janakpuri, and MKW Hospital, Rajouri Garden. Please come.
I'll even try to make it shorter. Again, old genes, love me, hate me, don't ignore me. This is what pertussis says. If you ignore me, I'll come back every 3 to 5 years to mess your life. So just let us rush through some new things that we can learn about pertussis. I'll just try to rush as fast as possible. This graph is the DPT-3 coverage, which shows that we have come a long way. In 2023, we are showing a 90% DPT-3 coverage. It is good also that we have achieved 90% coverage and the number of cases has come down. But we see that every 3 to 5 years, the cases, they start climbing. We can see from 1980 to 23, in between the graph goes down, again climbs after 3 to 5 years. But again 90 means that still 10 is left, and that can act as a reservoir, that can act as a pool, and we should try to make it full coverage as fast as possible. This slide is an eye opener. In Western India, in a mother-infant dyad, it was found that 87% of the mothers are seronegative for pertussis. That means they are prone to have an infection from the society. So this is very important. What are they going to transfer to the child? All the infants are at risk, and that is how the concept of giving DPT to the mother came, and that is you started giving DPT to the mother instead of TT in the 3rd trimester. So we know that adults are the transmitters, adults are the reservoirs, and we are going to get the infection from the adults. But they are seronegative, 87%. So they are all naive. So coming to the topic of today, we are mainly in the world of wholesale and acellular and shifting towards more of acellular. Acellular, we have up to maximum 5 components in a vaccine, and today in our kitty we have 2 component and 3 component vaccine, the basic difference being the pertactin. So we will talk a little bit more about pertactin. We know these 5 antigens very well, pertussis toxoid being the main, FHA common in both, and pertactin is the basic difference between 2 and 3 component. This pertactin is a part of the outer membrane protein, an autotransporter, and basically works by increasing the virulence, decreasing the phagocytosis, and helps in the attachment to the ciliated epithelium of the respiratory tract. So this is important. So what is the increasing relevance of this pertactin? It has been seen in Belgium, France and Slovenia. What they have found out is that way back pre-COVID area, we used to have most of pertactin negative isolates. But this has drastically changed in the post-COVID scenario, where you are having nearly 90% to 100% of the isolates, and they are now pertactin positive. So if your vaccine is pertactin negative, it will work less against the pertactin positive bacteria. So that difference is very, very remarkable. We can see that the ELISA and whole gene sequencing has shown that most of the cases are pertactin positive. This is in Belgium. In France, it was seen that 99% of the isolates were PRN positive. Again in Slovenia, 100% of those were pertactin positive. So this is what is changing. This is basically the nature's way of changing things and challenging us. क्या कर सकते हो? आ जाओ देख लेते हैं. So this pertactin levels are directly proportional to the level of phagocytosis. जितना आपका pertactin antibody बढ़ती जाएगी, उतनी आपकी phagocytosis better होती जाएगी. If you remove these anti-pertactin antibodies from the serum, in this we can see your phagocytosis goes down drastically, the red one. FHA हटाते हो कोई फर्क नहीं पड़ता. The orange bar is nearly the same as that of the control. So these anti-pertactin antibodies are very important. Their level is directly proportional to the level of phagocytosis that is going to occur in the body. Again, a French study in infants, it was found that you have fulminant like you have fulminant hepatitis, you have fulminant pertussis also. What is that? Your count is more than 40,000. And any of the factors like shock, pulmonary hypertension, multi-organ failure or respiratory failure, any of these, this is termed as fulminant pertussis. One of the risk factors was pertactin producing Bordetella pertussis. This adjusted related risk was nearly 4 times. So if you are using a pertactin negative vaccine, your risk increases by nearly 4 times. The other risk was prematurity and the early age, that is initial 6 months of age. So the value of pertactin is that it gives value to the vaccine, the efficacy of the vaccine increases, and although there is no accepted correlate, but higher pertactin levels are associated with disease protection. This we can see, this is a Cochrane systematic review of 6 randomized double-blind efficacy trials, which clearly shows that if you are using 1 or 2 component vaccines vis-a-vis 3 component or more vaccines, the efficacy is definitely different. It is nearly 60 to 78 vis-a-vis around 85% in the 3 component vaccines. So pertactin containing vaccines had a higher vaccine efficacy against both typical or mild than non-pertactin containing vaccines. So this inclusion of pertactin in the vaccine is associated with improved protection against pertussis compared with the 1 or 2 component vaccines. So how to corroborate this with the immunological data? We know whenever we are talking of protection against immunogenicity, long-term immune persistence, real-world effectiveness, which is most important, and talking about preterms, because the number of preterms is increasing day by day, we can say this is an excellent vaccine which gives you nearly 99 to 100% seropositivity, seroprotection against all the antigens, and especially we can see underneath these are the antigens against pertussis, and the seropositivity is excellent. It is to the tune of 97 to 100%. These have been tried in both the schedules, that is 6, 10, 14 and 2, 4 and 6. So both are very good working. We can use whatever suits us, but it was seen whatever you may take, one shows after 4 to 6 years, another is after 7 to 9 years. And the thing of interest here is that if we talk of anti-pertussis toxin antibodies, these are decreasing both at 4 years, these are decreasing both at 9 years. So this shows that antibodies are waning with time, and that is how the concept of a booster at 4 to 5 years and a booster at 10 years came into being. So this is more specific about pertussis, anti-pertussis toxin antibodies, whereas FHA and PRN sometimes may have cross reactivity with others, Bordetella, parapertussis or others, and may increase because of that also. But this is how the concept of booster at 4 and 5 years or 9 years came into being to boost the levels. So this is the real world effectiveness data. We can clearly see in Italy and Sweden it has worked wonders. After the DPT vaccination and a high coverage, we can see that since 1 decade back they have nearly cut down on the pertussis cases to a large extent, and this is of Spain, wherein we can see that vaccine effectiveness has reached up to the levels of around 86% after a 12-year follow-up, which is very, very high. So you maintain the levels, you continue vaccination, include more antigens, the more the merrier. This is regarding the preterms. It is a large number, more than 1600 studied, more than 24 weeks of age included, and it was said, it was concluded that the preemies should be vaccinated at the same chronological age using the same schedule, and as full term or normal birth weight infants according to standard guidelines, no changes are required as such. Even the safety is nearly the same as in full terms, because safety is of utmost importance and public tolerance for safety concerns is very, very low. So we should be very, very concerned about the safety of the vaccine before giving it to the VLBW, LBW or preterms. Negative experiences, they increase the risk perception and may impact vaccine compliance, as was seen with dengue vaccine. We all know that acellular vaccines, they provide a better reactogenicity profile vis-a-vis whole cell vaccines, not going into the detail. There are head-to-head trials between 2-component and 3-component hexavalent vaccines, and it was seen that if we are talking of local reactions or local injection site reactions, the 3-component vaccine score over the 2-component vaccine, we can see the odds ratio, pain, redness and swelling. All the three are less with a 3-component vaccine in comparison to the 2-component vaccine, and similar is the case of systemic side effects. All the fever, drowsiness, irritability, persistent crying, anorexia are clearly visibly less, as the odd ratio shows that they are lesser with the 3-component vaccine vis-a-vis the 2-component vaccine. Sometimes we think that more components are there, it might be more reactogenic, but the case is opposite. So it extrapolates to lesser number of redness, fever, pain and systemic reactions in our practice. So we can avoid a lot number of ARs with the doses of 3-component vis-a-vis 2-component vaccine, and this was a mathematical projection by Mukherjee et al. For France, and we can see if we compare the reactogenicity, the pain, redness, swelling and fever, these are the least in the 3-component vaccine comparison to the 1 and 2 component and WP vaccines. So summarizing, this is the only hexavalent vaccine with more than 20 years of use in clinical practice. Even the 2-component vaccine that we are seeing, that was launched after comparison with this 3-component vaccine only. So this was the one which was initially available. It has been used extensively in more than 100 clinical trials. You have a lot of confidence, lot of safety data, lot of immunogenicity, lot of effectiveness across the globe. So we can confidently use it. It is registered in 94 countries and more than 6 crores have been immunized. So to summarize, pertussis epidemiology is evolving. It is always evolving. Recently, there is a rise in pertactin positive strains which highlights the role of 3-component pertussis vaccine. The 3-component pertussis vaccine has shown up to 7 years of immune persistence, real-world effectiveness and optimal outcome even in preterms. A meta-analysis of safety outcomes has demonstrated that 3-component has a more favorable reactogenicity vis-a-vis the 2-component one, and reactogenicity outcome is superior not only in comparison to WP but even the other AP vaccines as such. Thank you.
Thank you, Dr. Pankaj. A very precise but complete information regarding the changing scenario. And if anybody would want to ask, I think they have a minute. Any questions? So do you advise that there should be a third booster considering the waning immunity and considering the advancing age of marriage? See, it's in pregnancy. Pregnancy after marriage could be 35, 40 years also.
Madam, CDC recommends that every 10 years we should give a DPT vaccine. Only in our country, because of the cost, we are recommending DT. Ideally, it should be DPT. Okay, because we are the reservoirs and we are going to transmit the infection to infants. So we have to be immune.
Plus the girl herself, you know.
They have to take the vaccine in the 3rd trimester of pregnancy.
Yeah. It's not only the newborn, it's even the mother. No, madam, she could be having low immunity and suffer the symptoms. So
I am telling for adults, every 10 years we should take
DPT.
CDC says that every individual after 10 years of age should repeat the DPT vaccine every 10 years. But in our country we say at 10 years you take DPT, 16 years you take DT, another every 10 years then you take DT. In our country this is the schedule.
Yeah, at present we are not giving.
CDC says 10 years DPT, 16 years DPT and then every 10 years DPT.
Now in pregnancy instead of DPT they are giving
DPT.
Yeah, but why wait till pregnancy? I mean, even for the mother herself, the symptoms could be there. Anyone else?
What is the maximum age of DPT?
Yes, sir.
Maximum age 70, 80 years. Maximum age.
मेरे को मतलब maximum age for DPT, Boostrix.
No age limit.
I'll check it and revert back. There should be an age limit. There must be an age limit. So I'll check and revert. Sir, thank you. Thank you, madam.
Thank you, Dr. Pankaj. Kindly go. Okay, sir, please. 3 lucky drawers में से निकाल.
गरम वाली में खाली है ना?
जो ड्यूटी दे रहे हैं उधर उनकी भी निकाल लेना. हो गया
वो पहले वाले में
करने वाले नहीं है felicity.
वो येलो वाले थे, रेड वाले निकाले बस. नहीं सिर्फ रेड वाले थे. So डॉक्टर अभिषेक मैडम आदि आप ही
no upper age limit. No upper age limit.
तो मैडम आप ही लकी ड्रॉ भी आप ही का.
किसकी बात कर रहे हैं?
लकी ड्रॉ में भी आप ही का नाम है.
Now we move to next session. What if not cough syrups? I invite chairpersons Dr. Anju Kumar and Dr. Prashant Seth. Dr. Anju Kumar is a senior pediatrician at Bhagat Chandra Hospital, and Dr. Prashant Seth, he is a senior pediatrician and past president IIP West Delhi. And moderator Dr. Vineet Sehgal sir, who is a senior pediatrician at Max Shalimar Bagh. Panelists are Dr. Deepak Kumar, Dr. Gaurav Sethi and Dr. Arun Agarwal. I request Dr. Vineet Sehgal to kindly introduce the panelists.
That is why the typical cough consultation looks like this. On day one, the mother will WhatsApp you कि सर मेरे बच्चे को जुकाम है और खांसी है, क्या करें? So you on WhatsApp reply कि saline drops डालो और थोड़ा अदरक शहद तुलसी काढ़ा दो. 2 दिन बाद फिर फ़ोन आ जाता है कि उसकी खांसी बढ़ गई, अब क्या करें? तो आप उसको एक कॉफ सिरप ऐड कर देते हो जिसमें यूजुअली डेक्स्ट्रोमेथोर्फन और CPM कॉम्बिनेशन होते हैं और बोलते हो बाकी चलने दो. Then she lands up on day 6 कि there is no improvement, खांसी बढ़ गई है, बच्चा सो भी नहीं पा रहा, रो रहा है, परेशान हो रहा है. So you add a लेवोसेट्रिजीन, you say कि PCM as per need दे देना, डेक्स्ट्रोमेथोर्फन बंद कर दो और एक और कॉफ सिरप कोई शुरू कर दो, मे बी नोस्कोपी. बट शी कम्स बैक द नेक्स्ट डे इटसेल्फ कि नहीं डॉक्टर साहब खांसी बहुत ज़्यादा बढ़ गई है, आप देख लो, इसको एंटीबायोटिक की ज़रूरत नहीं है, नेबुलाइजर की ज़रूरत नहीं है. तो यू राइट इन योर नोट्स कि चेस्ट इज़ क्लियर, एवरीथिंग इज़ नॉर्मल, बट अंडर दैट पेरेंटल प्रेशर आप एक एजिथ्रोमाइसिन भी लिख देते हो और कहते हैं अच्छा नेबुलाइज भी कर लेना है. एंड 2 दिन बाद पेरेंट फ़ोन करते डॉक्टर साहब आपने पहले ही शुरू कर दिया होता ना एंटीबायोटिक और नेबुलाइजर, बच्चा ठीक हो गया होता, देखो 9 दिन लग गए. सो दैट्स योर यूजुअल हिस्ट्री. बट देन नाउ कमिंग टू द पैनल डिस्कशन, I'll put the first question to Dr. Arun Agarwal sir. Why do we cough? Matlab, what is the importance or what is the physiology behind cough?
As we know that the cough is the explosive expiration of air from the lungs in order to clear the airway of mucus and any other secretions or any other foreign materials. And it is a protective reflex. It increases the innate immunity. And as we can see that the mechanism of cough, so there are cough receptors which are present in the pharynx, larynx and upper part of the airway like trachobronchial tree. And from these receptors, the afferent signals, they go to the medulla, and from the medulla to the cuff center, and through this cuff center they through the efferent nerves, they go to the lungs and intercostal muscles and abdomens, and these actions occur in this is called cough reflex arc. And the stimuli are like secretion, mucosa, inflammation, and this exogenous stimuli like smoke, particulate matters and cold airs. And the cough is both voluntary or non-voluntary control. And the severity of the cough receptors are exaggerated due to the URTI. So the children have more sensitive cough reflex which is easily triggered. And the immaturity of the immunity system also causes the inflammations which is more in sick children. So these are the causes and these are the some physiology which can elicit the cough.
So I think basically the parent teaching point is that you have to tell the parents that the cough is a protective reflex. So it is not a problem, it is something which the body is kind of doing to protect itself. So Dr. Gaurav, when you get a child in your clinic with cough, how do you kind of evaluate this child as far as the history goes?
So first of all, we look at the duration, whether it's just for a couple of weeks. Actually, acute cough, हम लोग भी सोचते हैं पेरेंट की तरह कि 2-3-4 दिन की होगी, but acute cough is defined as something which lasts up to 3 to 4 weeks even. Anything beyond 4 weeks is called a chronic cough, and it's well documented that even a simple URI can cause a cough which can last for 2 to 4 weeks. इको हो रहा है कुछ ऑडियो वीडियो वाले को. तो then besides the duration, the quality of sound, where dry cough is usually due to irritation of the upper airways, and wet cough, there's some mucus production, could be sinus involvement, could be lower airway involvement, and other barking cough hai, so that could indicate croup. That indicates the swelling in the upper airway. Then whooping cough, obviously we all know there's a paroxysmum, followed by a whoop, and even psychogenic cough, habit cough, it can be a honking cough, but only when awake. Along with that, we always ask for some associated features. कोई whistling sound है, सांस फूल रहा है, भागने में खांसता है, या exposure to dust पे खांसता है. Nocturnal cough could indicate either asthma or it could indicate a post-nasal drip. So that's more or less what we would look at in a history, quick history. मतलब इतना ही time मिलेगा.
So basically, हर cough कुछ अलग कहानी सुनाती है, and you must understand that कहानी. So Deepak, you are the pulmonologist. So when a child comes with cough, what are the red flags? When do you worry that this is not your usual cough that we are talking about? जो हमारी usual cough is the acute viral cough. So what are the red flags?
First of all, cough lasting for more than 4 weeks, it's changes to a chronic cough. It should be a red flag. Acute cough with respiratory distress, any signs of respiratory distress, and any history of choking followed by cough. That is also foreign. The suspicion should be there. Cough during feeding, cough for children less than 3 months of age. Audible sounds, could be stridor, audible, could be wheeze or auscultation. These are the red flag signs more of.
Yeah, so a chronic cough would be a worrying cough definitely, and then things like neonatal cough, neonatal onset, wet cough, etc. You have to think of something beyond your usual. So now the cough bit is done, we will go to the cough syrups. So why do we need cough syrups? Cough syrups रहेंगी तो आपका क्लिनिक हला भरा रहेगा. cough syrups नहीं होंगी तो बेचारा खाली सा क्लिनिक दिखेगा और पैसे ऐसे कोई नहीं मिलने वाले, खाली खिड़की के थ्रू देखो. So Dr. Arun, these are the usual ingredients in cough syrups. Just a quick comment on what do these do, what are their effects, side effects?
Actually, these are the common ingredients which are found in over-the-counter available medicines, and these are most of the times these are available in combination forms. So, like dextromethorphan, it is a cough suppressor and it acts centrally through the NMDA receptors, antagonisms. And about the effectivity, there are some studies which have been done in the past. One study has shown that it is no more effective than the diphenhydramine or the placebo, while some study have shown that it is effective in suppressing the daytime cough, like 21% more effective in suppressing the daytime cough, but not effective in nighttime coughs. But this study is also under doubt because there are no parameter to count the cough or something like this. And this, so as for the label, so it can be used for non-productive cough. And there are other uses also which have been approved by the FDA, like pseudobulbar effect or major depressive disorders. The side effects, as usual, these are the drowsiness, nausea, lethargy, dizziness, constipation, and through NMDA receptors, it can cause euphoria, dysphoria, hallucination, and it has the tendency to be abused also because because it can cause euphoria and other side effects like death in young children. And as per the recent guidelines, this type of cough suppressant should not be used in children less than 4 years, and that is the recent guidelines.
Well, I'll just cut you short for want of time, but the point is that there are so many components and most of them have a lot of side effects and efficacy is very doubtful, in short.
Yes.
I'm sorry to cut you short, but for want of time, I'll move forward. And there's just this brief study I would like to show you, that it was done in a tertiary hospital in central India, and what is important is to see in the red box that of all the FDC prescriptions, only 5% were rational. And if you were to look at right at the bottom, there was no awareness of ingredients of 29% of the FDCs amongst physicians. माने that we write these syrups out of habit. उसमें क्या दवाई जा रही है, कितना कॉन्स्टिट्यूशन है, हमको भी धीरे धीरे भूल जाता है, which is very dangerous. So, Gaurav, we get a lot of cough syrups, which I prefer to call more like cocktails or mixes. So, what are your comments on these common ones?
So, mostly 3 से कम ingredient डालना तो शान के ही खिलाफ है.
शान के खिलाफ है.
प्लस FDC में आ जाता, वो FDC कह रहा हूँ, DPCO में आ जाता है सिंगल प्रोडक्ट, सस्ता कर देती है गवर्नमेंट, तो वो एक चीज़ कुछ ऐड कर देते हैं. बट बेसिकली वी नीड डेक्स्ट्रोमेथोर्फन, पर उसमें साथ में क्लोरफेनर्मिन, फिनाइलेफ्रिन है. प्लस हम लोग कोई, जैसे आपने प्रिस्क्रिप्शन दिखाई थी कि हम ग्लिवोसिट्राजिन या फेक्सोफेनेडिन भी दे रहे हैं, तो 2 एंटीहिस्टामिन जा रहे होते हैं कि छोटे बच्चे को. एंड नाउ विद क्लोरफेनर्मिन फिनाइलेफ्रिन कॉम्बिनेशन बीइंग बैंड बाय गवर्नमेंट फॉर चिल्ड्रन अंडर 4 years, we hardly have use for this combination in young children. बड़े बच्चों में भी we would prefer a single ingredient one. जितने component होंगे उतने side effect. डोज मैनेजमेंट नहीं हो पाएगी. डेक्स्ट्रोमेथोर्फिन के हिसाब से दोगे, क्लोरफेनर्मिन की डोज ऊपर नीचे जाएगी. एंड यूरिनरी डिटेंशन इज़ वेरी कॉमनली सीन. अगर हम पूछें तो बहुत बच्चों में निकलता है, बिकॉज ये दीज आर नॉट रन ऑफ द मिल मेडिसिन, दे डू कॉज लॉट ऑफ साइड इफेक्ट्स. इवन विद द ब्रोंकोडायलेटर्स, ब्रोंकोडायलेटर की ज़रूरत है, अम्ब्रोक्सोल भी डाल दिया, चलो 5-6 साल के ऊपर के बच्चे में तो समझ में आता है, बट फॉर अ यंग इन्फेंट, for small children, now we have drops containing these 3 components for a small baby who has no chance in the world to expectorate. Yeah. We are giving a mucolytic and an expectorant to a 1 year, 2 year, 3 year old child who cannot expectorate. The child will, as we've been taught by our teachers, कि वो अपने ही secretions में drown हो जाएगा बच्चा. Why we are adding these? Just because एक confidentiality of prescription है कि अच्छा एस्थलिन लिवोलिन लिखते हुए तो ज़माना हो गया, तो चलो कुछ ऐसा नाम लिखें जो पेशेंट को पता ना चले, और उसमें दवाई जो जा रही है वो बच्चे को ही नुकसान कर रही है. सो वी शुड डेफिनेटली अवॉइड राइटिंग दीज फिक्स्ड ड्रग कॉम्बिनेशंस.
एंड इट डजंट स्टॉप हियर, है कि नहीं दीपक? यू उसके ऊपर से और ये चीज़ें और भी होती हैं. किसी में अमोनियम क्लोराइड होगा, किसी में सोडियम साइट्रेट होगा. सो एनी कमेंट्स ऑन दीज?
These are all toppings more of it's not of much use. Like ambroxol added hota hai, so we don't get that exact dose how much we have to prescribe. We just see the dextromethorphan, बाकी उसके बाद क्या है we don't know. Sometimes we are over giving that doses. Even menthol is demulcent, otherwise it has got no effect. These are all not a good product to add.
Cough suppressant with a expectorant, cough suppressant with an expectorant का combination भी बिक रहा है. तो
and what we must realize is that these are all legacy drugs. They came into being or came into use much before we had these strict randomized trials and everything happen, and these we have inherited. इनके एक्चुअली कोई बहुत ज़्यादा स्टडीज़ और एफिकेसी ट्रायल्स वगैरह नहीं हैं, बट we've been handed down over the generations.
Awareness was not there earlier. Nowadays awareness is
Dr.
there.
Arun, a quick response from you. Do we really need these cough syrups, these sort of cough syrups?
Yeah, as we discussed that I think there is no need of any cough suppressant, usually especially in the young children. And we can see that majority of the cough suppressant has no effect. Many studies have been done, but these have no effect in suppressing the cough. So we should have ideal cough suppressant. I think we don't have any ideal cough suppressant which has specifically acts on the peripheral receptors and not causing any side effects.
Hopefully by the end of this discussion we'll come to some consensus. Gaurav, you want to add something?
I was just saying, even ठीक है हमें लिखना पड़ता है, फाइनली फीस दे रहा है कि सर खांसी के लिए आए, खांसी की तो दवाई बताओ, मैं नाक में ड्रॉप्स और वार्म वाटर हनी तो मैं कर ही रहा हूँ, तो यू काउंसल देम कि देयर इज अ प्रोटेक्टिव इफेक्ट, बट बहुत परेशान हो रहा है, सो नहीं पा रहा, उल्टी कर रहा है खांस खांस के, तो SOS यूज़ करे एंड वो मेडिसिन यूज़ करे जिसमें कम से कम कंपोनेंट है और डोज आपको पता है.
So there have been reviews which say there is an unmet need. Cough syrups are needed. Unfortunately, we still don't have something very efficacious and safe at the same time. So, Deepak, any comment on the efficacy of these drugs?
Basically, cough syrups have more of placebo effect. Many many studies have shown that is the ECLIS 202-10. It has shown only almost hardly 15% were having effect and 75% were having placebo effect. That means the placebo effect is more of the cough syrup. It could be due to the demulcent, it could be due to any one drug effect, but multiple addition of drug is not good.
So generationally we've been using cough suppressants, but really if you go back into the studies, none of them have shown a definite efficacy, and all of them attributed to either a placebo effect or the effect of the other excipients or solvents which are added in the cough syrups. So there is a definite lack of evidence. I'll skip these slides for want of time and go forward with the discussion. So Gaurav, we have newer compounds, and I think we've been using it, at least you and me have been using it for a few years.
तो मैंने शुरू तो इसलिए किया था सर कि सब लिखते हैं डेक्स्ट्रोमेथोर्फिन, कुछ तो नया लिखूं, तो I started using levocloperestin जब ये launch हुआ. I read about it and there were few studies which showed that it's better than dextromethorphan, it's better than pure antihistamine, and obviously better than placebo and a good safety profile. So I started using. Finally at the end of the day you realize कि almost similar to others but slightly better than dextromethorphan, which studies are also showing. Levodopa is safer because it only adds peripheral cough receptors. जो airways में cough receptors हैं उनमें जो neurotransmitters हैं उनको suppress करता है, cough eliciting neurotransmitters को suppress करता है. Levocloperestin works both peripherally and centrally, so has some potential of drowsiness and other things, and both of these are not approved for children under 2 years, which unfortunately I am guilty of writing 1 year plus, but out of something, but as and when required for severe cough ऐसा लिख देते हैं उसमें. And levocloperestin is not recommended for wet cough, that's written. तो I learned this from a patient called back and said कि डॉक्टर साहब ने दवाई लिखी है और ऊपर लिखा हुआ wet cough, ये तो नेट पे लिखा है कि दिस इज नॉट फॉर वेट कफ, नॉट टू बी यूज्ड, एंड यू गो बैक एंड रीड एंड एक्चुअली DCGI की जो भी गाइडलाइन है उसमें लिखा है 2 साल से नीचे नहीं देना और वेट कफ में नहीं देना है, बट दे आर मोर इफेक्टिव एंड हैव बीन फाउंड टू बी सेफ इन children above 2 years.
And the saving grace is that they are still available as single component syrups.
आ रहा था अभी तक, अब इसमें भी वो डालने लग गए हैं, क्लोरोफेनोलिन डालने लग गए हैं.
CPM के साथ आ गया बिलस.
डेक्स्ट्रोमेथोर्फन के लिए भी पहले यही सिखाया हुआ था.
चलो, another recently introduced syrup. Deepak, your comments? Glycerol syrup आने लग गई as a cough syrup.
Actually, glycerol is not new. Glycerol is have been used as most of the cough syrup because it is used as solvent for the composition of this. It has got demulcent effect, and sweetness is the most important factor that for what they are using, and it's lubricate the pharynx and which decreases the cough.
But again, efficacy is
not known.
ये जब लॉन्च हुआ था मैं बहुत खुश था कि एक पहला कॉफ सिरप आया जिसमें कोई दवाई नहीं है. काम तो दवाई ने करना नहीं है, काम तो आपकी प्रिस्क्रिप्शन, प्लेसिबो इफेक्ट, आपकी काउंसलिंग नहीं करना है, तो एटलीस्ट यू कैन राइट समथिंग विच इज सेफ.
बट ये कंट्रोवर्सी का पंगा हो गया. ये कंट्रोवर्सी रिसेंट का थोड़ी और मुश्किल होगी कि ये अल्टरनेटिव इसमें था, वही है इसमें.
नहीं, we must differentiate between glycerol and DEG. वो that's अब टाइम नहीं दिया है, जल्दी सर दादी माँ के नुस्खे सर कवर कर लो फटाफट. दादी माँ
अल्टीमेटली हम जो है दोबारा से उसी जगह आ गए हैं, दादी माँ के नुस्खे जो हम बचपन से करते हुए आए हैं. एंड वी कैन सी दैट द हनी, जिंजर, तुलसी, आयुर्वेदिक कफ सिरप के लिए थोड़ा डाउटफुल है, पर अदर कॉन्कॉक्शन एंड कफ लॉजेजेस अदर कंकॉक्शन के अंदर नेल्सन में इग्नेशिया डिस्क्राइब किया हुआ है, विच इज़ नॉट अवेलेबल आई थिंक इन इंडिया. इट इज़ अवेलेबल इन अमेरिका, दैट इज साउथ अमेरिका. Otherwise, the vapor rub, that is the Vicks vapor rub, some studies have shown that it is effective, and we have been using since our childhood. So I think we have again come to the same point. So these are the things. Honey is better.
हाँ जी मैम. अपनी पर्सनल एक्सपीरियंस हर किसी के हैं. What would be an ideal cough syrup? अब मैसेज जाने चाहिए फाइनल 1 मिनट में मैसेज.
मेरे हिसाब से आइडियल कॉफ सिरप तो समय है. टाइम इज़ द अल्टीमेट हीलर, बट वो टाइम गेन करने के लिए पेशेंस चाहिए पेशेंट की. तो माई टाइम, इफ़ आई स्पेंड टाइम इन एग्जामिनिंग द पेशेंट वेल, टेकिंग अ हिस्ट्री, आई कैन मेक आउट कि अच्छा ये मोस्ट लाइकली कॉज है. इफ़ आई नो द कॉज आई कैन ट्रीट इट बेटर. इफ़ आई एम कॉन्फिडेंट कि मैंने सारा कान, गला, नाक, चेस्ट अच्छे से देखा है, तो आई कैन काउंसिल देम बेटर. और वो पेशेंट मान जाएगा 5-7 दिन के लिए. उसके बाद आएगा तो फीस भी रिपीट हो सकती है 5-7 दिन के बाद. तो बट बेसिकली टाइम के साथ चलें एंड ट्राई टू मेक अ रफ डायग्नोसिस कि क्यों खांसी हो रही है. ओनली देन इट विल वर्क. अलॉन्ग विद सलाइन ड्रॉप्स, रेस्ट एंड हाइड्रेट. रेस्ट में वी मस्ट ऑलवेज आस्क कि ये क्या कर रहे हैं घर पे, बिकॉज हम तो कहते हैं, हमारे को तो कहते हैं कि बहुत खांस रहा है, बहुत खांस रहा है, और स्कूल जा रहा होता है बच्चा, या पटाखे चला रहा होता है बच्चा, या आइसक्रीम खा रहा होता है. तो दे आर ईटिंग योर हेड कि बहुत खांसी है, ठीक नहीं कर पा रहे, एंड दे आर नॉट टेकिंग एनी अदर प्रिकॉशंस. सो प्रिकॉशंस आर इंपॉर्टेंट. रेस्ट, हाइड्रेशन. सिंगल इंग्रेडिएंट कॉफ सप्रेसेंट के लिए वी मस्ट पुश द इंडस्ट्री कि वी वांट प्लेन डेक्स्ट्रोमेथॉर्फिन, वी वांट प्लेन लेवोक्लोपेरेस्टिन, वी डोंट वांट दीज कॉकटेल्स. एंड अगर डिमांड है तभी बिक रहे हैं, तभी तो वो बना रहे हैं इतने सारे कॉम्बिनेशंस.
Medical legal position, I think
Medical
all of
legal
us
position,
now
I think
know.
everybody knows about this, and these are the key points.
अब latest यही है. Latest ये है कि
no
cough
cough
syrup
syrup under 2 years and 2 to 5 years under supervision and guarded, and these are the rest of the things which are already discussed.
ये गवर्नमेंट की तरफ से आ गया.
ये गवर्नमेंट की तरफ से.
So Deepak, what do you want in a cough syrup? Previous slide. ये वाली. अच्छा, फोटो खींचनी है. ये भी ठीक है, फोटो खींच लो, हम बोलेंगे कुछ नहीं. दीपक, आइडियल कॉफ सिरप तो खैर गौरव ने बता ही दिया. So what do you
it should
want?
be single component. Rational should be component. We should talk with the pharmaceutical company before starting कि multiple drugs नहीं होने चाहिए. जैसे mucolytics है, it's Amroxol, it's like a combination therapy should not be there, and strict quality control should be there. जो last incidences हुए, it will decrease down.
चलो जी. And just to finish off, the last word तो यही, art of medicine consists in amusing the patient while nature cures the disease, and it works best for cough. It's nothing else. So big thank you.
This one is recommended even for infants by 1 term. Small infants. Is it justified?
No sir, FDA approves more than 4 years.
So DCGA should not approve it.
No, it should not. But ideally it should be more than 4 years.
बाकी ऐसे रश में final last words होते हैं कि rest can be discussed over a cup of tea. So
what we can say is the recent tragedy, though it was a tragedy due to cough syrups, has made our job easier. Yes, at least we can say, tell the patient, आपको पता नहीं है कि cough syrup आपको नुकसान होता है. So we have a way of
वो that's a huge separate discussion altogether.
मेरा टेक ये है सर कि जैसे क्लोरफेनोलिन फिनाइलेफ्रिन कॉम्बिनेशन हम बहुत लिखते थे, अब 0 कर दिया है, फिर भी जुकाम ठीक हो ही रहा है, तो कॉफ सिरप बंद कर देंगे लिखना तो भी खांसी ठीक हो ही जाएगी. आप स्माइल करके जब पेशेंट को कहोगे बेटा 5-7 दिन में ठीक हो जाएगा, आपका पेशेंट वैसे ही ठीक हो जाएगा.
नेल्सन ने तो रिकमेंड किया हुआ है जो आपके
सर ये है कि अगर इफ़ यू आर टू लुक एट दी, क्योंकि रिपोर्टिंग सबसे अच्छी यूएस में होती है, जितनी भी कॉफ सिरप से साइड इफ़ेक्ट्स रिपोर्टेड हैं, एडवर्स इफ़ेक्ट्स, दे आर entirely always due to overdose or deliberate ये नशे के लिए abuse, sorry, so in the usual pharmacological dose of dextromethorphan CPM there are no reported side effects, but it's been painted that way. Vikram.
कि आपको जब पेशेंट से पूछना है कॉफ की फ्रीक्वेंसी, साइड इफेक्ट, no one is able to get clear answer.
Yes.
वो परफॉर्मर बनना ही डिफिकल्ट था. So we could conclude कि मुझे जो कॉफ सिरप की स्टडीज भी करनी है वो भी इतनी टफ है कि
I think हमने ये स्लाइड में टाइम नहीं था बट लिखा हुआ था.
It is mentioned in the slide also.
कई बार यही नहीं पता चलता वजह से है कि फिनार्गन की वजह से हो गई. इट कैन हैपन.
कोई पैरामीटर नहीं है उसको मेजर करने का.
Dr. Smita Mishra ma'am, please, time for the lucky draws.
ये हिंट था, फिर मेरा ही निकाल लिया.
Yeah.
Dr. Rakesh Mahajan sir. Sir, listen with me, sir. With me. Dr. R. Malhotra.
So now it is made up.
कोई पार्शियलिटी है भाई, राकेश कैसे हो रहा है?
Now next session is best practices in management of febrile seizures. I invite chairpersons Dr. Anita Sharma ma'am, Dr. Rakesh Mahajan and Dr. Harsh Gupta. Dr. Anita ma'am is a senior pediatric neurologist at Dwarka. Dr. Rakesh Mahajan, senior pediatrician at Mahajan Hospital. Dr. Harsh Gupta is at Acharya Bhikshu Hospital. He is a senior pediatrician there. I invite Dr. Rasika madam as speaker, and I request Dr. Rakesh Mahajan to kindly introduce Dr. Rasika.
For choosing this topic, I think this is the topic which is in best in life, line with the tagline of this conference of everyday dilemmas, and I expect to give you at least a ordinary insight to the problem. So let us shoot. I would like to start with this two cases. So case A and case B. I hope most of you must have faced this kind of a scenario where you have a, let's talk about the case A, which is a 9-month-old male child. Came with a history of fever, tonic posturing, no significant history, mild irritability, the AF is open and pulsatile, CNS normal examination. The case B is a 25-month-old child who is having a history of febrile seizure. There is no other significant examination finding. So, with fever more than 101 degree Fahrenheit in the age group of 6 months to 6 years. Now, I would like you all to please remember the 6 years, because most of us are used to the older guideline of 5 years. Now it is 6 years. Without serious infection, any metabolic disturbances, history of febrile seizures prior, or any other acute neurological insight. Then we classify it into a simple or a complex febrile seizure. So when we talk about a complex, it includes either a focal or a prolonged seizure for more than 15 minutes, and it may occur again within 24 hours, so more than 1 seizure. When these seizures continue for more than 30 minutes, it constitutes the febrile status epilepticus. If it is the child is having the seizure even after 6 years of age, then it becomes a febrile seizure plus. Now, if there is a family history of febrile seizures or febrile seizures, it becomes a genetic epilepsy with febrile seizure plus. So these are some common definitions we all need to remember. A quick touch on the newer updates about the idiopathogenesis. So there has been a very recent article which has come up in 2025 June about the pathogenesis of febrile seizures. So we all know that infection, vaccination, or intestinal dysbiosis leads to neural inflammation. And this neural inflammation causes fever and release of pro-inflammatory cytokines. So these cytokines cause the neuronal hyperexcitability, causing febrile seizures. Now, this is always in question the ion channel gene mutations, which may predispose these children with fever to febrile seizures. So there is a good role of this gut microbiota. The recent guidelines, the gut-brain axis, which is always in talk now about whether you're talking about autism or epilepsy, here it again has a role. The research is still at a very preliminary stage. I hope we get something good out of this further. Now, the guidelines for the management of febrile seizures have been coming from 2008, the Italy guidelines, to the recent ones which were by our own Indian neurologist from Delhi, who have constituted this AOCN, Association of Child Neurology guidelines, which have been followed worldwide now. So, whom do we admit? Any child who is less than 18 months, a child who is having a complex febrile seizure, not able to reach the hospital early, or there is parental anxiety, we admit them. Now, for the febrile seizures, what I should send and what I should not send. CBC is not required in all the cases of febrile seizures. Complex febrile seizures or febrile status epilepticus you may send. The routine investigation, like we are sending electrolytes and calcium in all children, not required. They may be considered in children who are convulsing and come to the ER in a febrile status epilepticus or complex febrile seizures. Serum calcium may be done in children who are less than 1 year age. Again, micronutrients deficiencies, iron deficiency, only a clinical pallor is present. The rest also, like the vitamin D, if there are signs of rickets or if there is hypocalcemia. Urine analysis, if there is no other focus of fever. We all know that the RSVs and the influenza are usually the triggers for these febrile seizures. So if you are not able to find anything in the history, you can definitely go ahead with the urine examination. Now coming to the CSF examination, this is again a traumatic thing. It is a invasive procedure, so we need to think it is done in all children who are giving you clinical signs of meningitis, in children who are less than 12 months of age with first episode of febrile seizure, or children more than 12 months age who are pre-treated with antibiotics. When to do? It has to be done after the neuroimaging, and if you are seeing any focal neurological deficits or signs of raised intracranial pressure. You send a routine CSF examination. If it is suggestive of any meningitis, only then you go ahead with the viral or the bacterial panel accordingly. Where do I do MRI? MRI is indicated only children with complex febrile seizures and with prolonged or focal features. They are not indicated in any child with febrile seizures, simple febrile seizures. They usually should be done within 72 hours. What am I looking at when I get these films? I am looking for acute disseminated encephalomyelitis because this is one close differential for a child presenting with seizures, which I want to treat in a different line of treatment. So this is what I am looking for, and that is why I am doing the MRI. EEG, not routinely indicated in febrile seizures. It is done if again we have complex febrile seizures or there are focal findings on the neuroimaging. Usually within 1 week is the timeline when we should do. Earlier there was a discussion whether we should do it within 24 hours, 1 week later. So now the guideline says it should be done within 1 week of the febrile seizure. The prognostic significance is not much. Going ahead to the genetic testing, we don't want to land up into this situation where we are looking at the report and don't know what to do with it. So we do it only in children where we are suspecting Dravet syndrome or in specific genetic epilepsies. So I would recommend you all to kindly get in touch with a pediatric neurologist or a genetist before testing for the seizures. Treatment. Antipyretics, paracetamol is the drug of choice. We have to give it at 6 hourly to elevate the fever, but yes, it does not prevent the occurrence or recurrence of febrile seizure. So giving paracetamol is not what is going to help the child not have a seizure. Micronutrient supplementation, not recommended. Now, intermittent prophylaxis. What do you give? You give clobazam 0.5 to 1 mg per kg per day for 3 days. If fever, anytime they are giving a paracetamol, they are supposed to give it for the 3 days along with it. Who do you give? The seizures, who are recurrent, simple febrile seizures with parental anxiety, who have no access to medical facilities, or complex febrile seizures, who have not been put on long-term prophylaxis. Now, whom do we give the continuous prophylaxis? This is given to children with febrile status epilepticus, with febrile seizures with neurodevelopmental delays, with children having frequent complex febrile seizures and febrile seizure plus or genetic epilepsy with febrile seizure plus. You start with sodium valproate, which is the drug of choice. Parental education. This is the most important thing that we are doing in management, because the trauma to the child, the mental state of the mother, everything is important. You need to tell the mother that your child is not going to die with a seizure, which is very important. The child's brain is not going to damage if the child is getting a febrile seizure. You need to tell what to do, the first aid during a seizure, and how to prevent. And lastly, the recurrence risk. So the recurrence risk of febrile seizures, there are some risk factors which will give us a clue of if it can come again. One is the age, which is less than 15 months. Second, epilepsy or febrile seizure in the first degree family relative. First episode presenting as complex febrile seizure or social or community setting. So if there is no risk, I mean if this child has one febrile seizure, the possibility that he will again have a seizure is 12%. If you have one risk factor, it comes to 25. If you have 2 risk factors, it becomes 50. With 3 or 4, the risk goes to up to 80% risk of recurrence of febrile seizure. Now, what about the risk of epilepsy? So, when you have a child with simple febrile seizure, the risk is 1% at the age of 7 years. So, this is risk of epilepsy. It is 2.4% at the age of 25 years. आगे क्या होगा? मेरे बच्चे को आगे क्या होगा? This is the most important thing that every parent is nagging you with. The higher risk is there if the child is having multiple simple febrile seizures, if the child is having less than 12 months at the first episode of simple febrile seizure, and there is a history, family history of febrile seizures. Now, in complex febrile seizure, the number of the complexity that the child is having will give you the percentage of how much is the risk. So if 1 is present, it is 6 to 8%. If it is 2, it is 17 to 25%. If it is 3, 50%. That's really high. And risk factors for developing subsequent epilepsy, randomly we can say family history, if there is any neurodevelopmental delay, any focal signs, and febrile status epilepticus. So what we do? We recognize that the child is having the red flag signs or not. We recognize whether it is simple or a complex febrile seizure. We consider to start antiepileptics or not, and of course the impact on the family, the impact on the recurrence. I would like you all to just think about this slide a bit. This is the spectrum of seizures starting from the age. So the red line is telling you about seizures associated with fever, and the yellow is the febrile seizure. This is a very important slide, and this will give you an age mapped idea of when you have to think about what you have to do. This is the algorithm which we all, I think, should have by heart of now what to do if you have a child with febrile seizure. This is a downloadable, easily open downloadable PDF which will be available if you go and type AOCM Research Guideline 2022. So if you follow this, I think that is what is my job is done. Key recommendations: first episode of febrile seizures, routine, not required. Then if conversing to the ER, febrile status or if clinically indicated. First episode, again the routine lab is not indicated unless there is calcium deficiency or rickets. MRI brain, if complex febrile seizure. EEG, only again if complex febrile seizure, the prognostic significance is not very predictive of future epilepsy. Lumbar puncture in all children less than 12 months age, and if more than 12 months but treated with antibiotics. In the parental counseling and the prophylaxis we have already discussed in detail. I think that is what ends my talk. I have been very thoughtful about just giving you the gist of it. I would also like you all to be aware of the epilepsy, because my job is to spread the awareness about epilepsy. This 17th of November we are celebrating the National Epilepsy Day, and the whole month, Anita ma'am will agree, we all try to help all these children with epilepsy have a better life. Thank you.
Thank you so much, and to be very precise and to the point information which is required for a general publication. I would just
There are settings where the child is, suppose like the child is in a boarding school. So for that situation, the child needs to get admitted, need to be observed. There's no one along with the child to observe. And for prophylaxis also, when the child is not taken care of.
So there are no immediate caregivers?
Yeah. That is what it is.
One clarification, the role of clobazam for a simple febrile seizure. Any complex febrile seizure we are setting aside.
Yeah.
Simple febrile seizure, let's say 2-year-old. You said clobazam and then you said the indications. Clobazam is to be advised for all simple febrile seizures for next fever, because we don't do that.
No, sir, not for simple febrile
paracetamol and
seizure.
nasal deslam if required.
Right. It is if it is recurrent febrile seizures. Only if the simple febrile seizures are recurrent. If they are more than 2, like if in a year, there is no exact definition put up. But yes, for what we practice is like if in the one season, like if in 6 months the child is having 2 episodes, every time the child has fever, the child is throwing a febrile seizure, then so that we just avoid the admission for a
The
child.
onset of fever. Otherwise, for simple febrile seizure, once in
Not
1 or 2 years, no.
Not recommended.
Only midazolam as
Yes.
Other than number, the parental apprehension is also very important. If parents are very apprehensive, then you can give intermittent, otherwise not much indicated per se.
So, but what we usually do is we give midazolam to the parents to relieve their anxiety. Once they know that they can abort the seizure, I think their anxiety goes down quite good, that something is in their hands.
And sometimes we are instructing that they have to use only after 5 minutes of seizure. If seizure continue for 5 minutes, then you use midazolam, otherwise
Yes. So it is not to be given immediately. It is only the standard guidelines of using midazolam, if the seizure lasts more than 2 minutes, only then we use it.
The other thing which I would like to say is that we should be aware of the Dravet syndrome is one, because that starts in a pre-morbid child which is normal, and over the time if you have a child who has got seizures which are changing the sites, requiring hospitalization, prolonged seizure, there one should be thinking of this, because the development becomes stagnant only after some time. And the one more thing which I wanted to say about the previous talk, we were talking about the inhalation of eucalyptus oil and all that. They are also seizurogenic. So that should not be. Sometimes what happens is that the parents will cut it, or they will put that under the pillow or something, because some days the child may throw seizure also. So one has to take precaution there also. It should not be too much.
And ma'am, these days the role of iron deficiency in causation of febrile seizure, any comments there?
Yeah, so the slide that I showed, so the recent review that has been done in 2024, on the June 25, the article has come, which is not showing, they have done a randomized controlled trial. There are no randomized controlled trial, they are only prospective or very small group studies. So they have not been able to infer that iron deficiency is directly related to the incidence of febrile seizures.
But it is written in Nelson that it is associated. And based on that, one of my DNP did study on that also. So both iron deficiency per se and iron deficiency anemia is associated with increased risk of febrile.
It is agreed, sir, but not in the
agreed, sir.
To this point.
Yeah. So the research does not mention it, sir. The consensus guidelines.
Nelson, it is mentioned in Nelson.
Yes, it is.
Even earlier, zinc deficiency was also said to be, and there were theses long back on this topic also.
So because most of the kids, in my study, most of them had some iron deficiency.
So this AOC 2022 guidelines, these recent guidelines are telling us that we should not be considering this micronutrient deficiencies. This is got up from all the nationwide studies, and no evidence is there, sir. So probably we are lacking. We should push up and publish these studies so that we may be able to make it better.
But when we look at iron profile, when we do any CBC, which is showing some iron deficiency anemia, or even the anemia is not there, some iron deficiency is there. Anyway, because iron, every study says we need to supplement.
So what I think is, in my
Deficiency
personal
opinion, but whether the two are related is not substantiated by the studies. That is what. But Nelson, whatever you are saying, does not.
So, sir, what happens is fever. This iron deficiency makes these children more susceptible to infection. I think that is what is causing this vicious cycle of these children getting more infections and then landing up into febrile seizures. That is how.
Is not known. That is what you can say, but because there are no studies, and that maybe it's a Western literature. We don't have one, so that.
Thank you, Dr. Asya, and thank you all the chairpersons.
Next topic. The topic is Beyond the Trial, the Real-World Effectiveness of the Rotavirus Vaccine in Low-Income Nations. To chair the session, I would like to invite Dr. Supriya Gulati. She is a senior pediatrician at Vikaspuri, and Dr. Kiran Agrawal. She is an ex-senior consultant, Hindu Rao Hospital, and past president, IAP Delhi. And to deliver the talk, I would like to invite Dr. Satish Sharma. Sir is a medical director, Arca Super Specialty Center, Dwarka, and he is a secretary, Medical Legal Chapter, IAP. Please, sir.
Yeah, good evening, friends. About the rotavirus vaccine, all of you have been using more than a decade, so just to refresh your knowledge. And this slide has been taken from WHO pamphlets, and about this how the infection, the mode of spread, and what are the symptoms. I'm not going to detail. And the diarrheal deaths, global deaths, the cause of death under 5 mortality in children, and diarrheal disease accounts for the third in more than 5.3 lakhs children they suffer globally. And this and these related deaths, if you see globally in 2019 there were 19.1% global death, and out of these around 49% of these they were in Southeast Asian country, Africa and Oceania. And if you see this diagram here, then India comes in these 5 to 10% of the all global deaths. The leading cause of diarrhea in children under 5, and first this rotavirus, if you say in age up to 1 year of age, and the diarrheal, the rotavirus is the first, in addition to other causes like Campylobacter, Shigella, other enterovirus infections. And in the age group 1 to 2 years also, the rotavirus is on the first in the list and the causing one of the cause of the death. And over 90% of the deaths occur in the low and middle income countries. If you see the structure of this rotavirus vaccine, all of you know that there is a nucleoprotein inside this RNA, and these two proteins which are very, very important is VP4. This means this is P serotype and this is protein sensitive proteins, and the other one is VP7. This designates G serotype of the strain of the glycoproteins. And when we say G1, G2, G3, they are designate that G serotype referred by the number, and P genotype they are denoted by in brackets like P8, P14, P6 like that. And this they developed oral rota vaccine strain 116E strain. This was developed from the asymptomatic neonate, and this state was naturally resultant, and this was first studies in AIMS in 1985, Dr. Bhan and his team, and then this virus was given to Bharat Biotech in 2001, and that the vaccines were developed at National Institute of Health in USA, and this strain was G9P11 with one segment in VP4 of the bovine origin, but all other segments they were of the human origin. So this is slide they showing all are human origin. The source of rotavirus vaccine, if we see in market what are available is Rotarix, available earlier, but now it is again have been launched in the market, and Rotatec, the 5-valent, Rotacil 5-valent, then Rotavac by Bharat Biotech, and the strain they are in Rotarix is G1, this is monovalent, Rotatec is 5-valent, contains G1, G2, G3, G4, G6, and the Rotacil again they are G1, G2, 3 and 9, and if you see this monovalent Rotavac is G9 human strain and P11 human, this 116 strain. The receptor they are this L strain, but no, the receptor they are not known in Rotatec and Rotacil, but in Rotavac they are type 2 precursor strain. And if you see this volume, the volume is 1 ml Rotarix, 2 ml in Rotatec, Rotacil 2 to 2.5 ml, but in Bharat Biotech vaccine, Rotavac is only 5 drops or 0.5 ml, which is easy to administer. Regarding the storage temperature, 2 to 8 degrees in all these vaccines, they are 2 to 8 degrees. If you see Rotavac earlier, which are available, was minus 20 degrees, but now the Rotavac 5D, which is available, 5D mean 5 degrees centigrade. It can be stored at 5 degrees centigrade also. So this 116 strain, they isolated from asymptomatic, as I have told you, and it replicates in the infected newborn without causing the disease. And due to binding of P11 to this HBGA type precursor, which may be ideal for the even the birth dose also then. This is called HBGA gut receptor. This is a new strategy for RV vaccine. The histo blood group antigen as a receptor for rotavirus. And these receptors are present only with this one and not with first vaccine and the other vaccine. These are P2 precursor. So this HBGA rotavirus host interaction, the histo blood group antigen are fructose containing carbohydrates, serve as an attachment factor or receptor for the enteric virus pathogens such as rotavirus vaccine, and interaction with HBGA rotavirus vaccine are mediated by VP4 protein on the surface protein. So this is given here, and again the human gut naturally they are present in the right from the birth. Now about the studies across the world, these are data are available. That if you see all these Cincinnati, this children hospital, they are from other Chile's, there's other all over these are world, there are data available. Then Malaysia, and then from India also Bharat Biotech, and a lot of other countries they are participating. Southeast Asian country also, Vietnam also, and Mongolia also. These are the these center studies are there all over. The phase 3 trial. This study was published in Lancet Efficacy of Monovalent Human Bovine 6C Rotavirus Vaccine Indian randomized double-blind control study with placebo, and they say that in the first year the efficacy of this vaccine was 56%, and this efficacy was in second year it was 55%. Again, this was safety trial, and that there is no serious side effects are there available. No new cases beyond of the interception were reported in the studies, and minimum interval between dosing and interception was 112 days. Cross protection, this is very, very important because this is a single strain, this is monovalent vaccine, and many companies, many persons will say, sir, R is the best because it contains the 5-valent or pentavalent. But this causes a cross protection, and this cross protection is heterotypic type of cross protection. And these studies indicate that this gives protection to other strain also, and this is authenticated by many studies in developing countries like Ghana, Mali, Kenya, South Africa, Malawi, Bangladesh, India. If you see that Rotatec, all these studies indicate that the number of group in Ghana, Rotatec was 2200, then 1600. So if you see in India, the two studies were Rotacil serum and the Rotatec Bharat Biotech, and the number of subjects was quite high, 7,605, and this study was done over a period of almost 20-24 months. And if you see the efficacy of the last line, that rotavirus gastroenteritis in Rotatec, all there was 48%, 17% or 40%, Rotarix 38%, and then Rotacil 39%. But this Rotavac, this 56.3% in the first year and 55% in the second year. And if there is no co-infection with other viruses or other Campylobacter like that, so efficacy would have been increased more by 11.3%, should have been 66 or 67%. And these were and this efficacy has shown promising durable efficacy in 2 years also. And impact on rotavirus efficacy, this is co-infection. If the co-infection exists, then like with the enteropathogenic E. coli or other Campylobacter or Cryptosporidium, then efficacy of the vaccine are increased. And if there are no co-infection, then efficacy increased by 11.3%. Then expanded program immunization, non-inferiority study, this was done, and Rotavac does not interfere with the immune response to other vaccine which give 6 weeks, 10 weeks, 14 weeks. Other vaccine we give polio or DPT or pentavalent or hepatitis B hip, so the efficacy is not affected of the rotavirus as well as the other vaccine. Non-inferiority trial with Rotarix, the first vaccine was it was non-inferiority trial was the one with the first available is Rotarix, and we find that geometrical mean titer concentration of Rotavac as compared to Rotarix, they are almost the same, 20 or 24%. On the right side, there were IgE secretory antibodies, serum IgA level, they were blue, and this pink diagram, they are almost post-vaccination development of the secretory IgA. And this was almost the same in both the licensed rotavirus vaccine healthy infants. Then 5D, earlier it was Rotavac, this was 0.5 ml, but it was to be preserved at -20°. Whatever available in the government setup, in government this is the same, and there is no buffer, no stabilizer. But then it was changed to Rotavac 5C, in which the volume was decreased to 1.5 ml to 2 ml, but the storage was 2 to 8 degree, there was buffer and there was stabilizer. Then to decrease the volume, manufacturing was done, so it was called 5D. So there are many, they ask what is this 5D? So this is just 5 degree, they are stabilized, can be stored at 5 degree. the volume is very less, 0.5 ml, can be stored to 20 degrees, no buffer, but only the stabilizer is also in this. So there is ease of administration with this, 0.5 inside of the cheek. Intussusception. New England Journal of Medicine, they reported that the intussusception, whatever occur, is the mostly case in the first 7 days of administration of this vaccine. And the dose, first dose they are more, and then in the 8 to 21 days. So this Rotavac product in India was not associated with any intussusception in the Indian infant, this study indicate. Then heterotopic, this is very, very important, that this monovalent 116E, it gives cross protection to all the other prevalent, that like G1, G2, G3, other vaccines they are. So 9 strains they are protected against this. Again the impact, this was the latent study of 2025. This studies was done in 9 states, 35 one center, and this was published in October 2025, latest studies. This says that 54% this study was done by the government. This is not any private institution studies. And this indicates that protection is not specific to a particular serotype, not the 116C, G9, but it protects all other genotypes and if it is available. And this again Indian government follow-up studies were there. This was the government of 31 hospital and 9 states, and this have shown this result were same as when the vaccine was launched after the efficacy phase 3 trial. Because the government was thinking that we introduced and what are the data up to 4 years. So 19, so to 2024 this study was done. So 54% this study was done in infant from 6 months to 59 months, and they say the efficacy was 54% against all this serotype G3, G1, G3, G9, all this they were efficacy, and there were reduction in the diarrheal disease. Most of you will think that now we are start getting less cases of rotavirus diarrhea in our practice. Why? Because the government is also using, we are also using. So there is definitely there is decrease in the prevalence and of the rotavirus infection. Thank you very much. Yes. Any question, query? Thank you very much.
Thank you, sir. Next, we have a very good session on the ABCs of the CBCs. For that, I would like to welcome the chairpersons, Dr. Ripdaman Kaur. Ma'am is at DDU Hospital. She is a unit in charge, senior pediatrician. And I would also like to welcome past secretary, IAP West Delhi, Dr. Shravan Gupta, practicing at Vikaspuri. As a moderator, we have Dr. Mukesh Dhankar, a very good friend of mine, is a hemato-oncologist, Professor Kalavati, Saran Hospital, needs no further introduction. Dr. Mukesh, I would want you to please introduce and welcome the panelists.
Thank you. So,
Sorry, just taking one more minute. इसके बाद जो last session है डॉक्टर मनिंदर का, we would be shifting it to the Nelson 2. We'll club both the rooms and have a session there. Doctor.
So thank you for this opportunity for this panel discussion of Beyond the Basics ABC of CBC and Enigma of aplastic anemia. I have panelists with me, Dr. Amrit Kaur. She's a DM pediatric oncology and currently working at Max Dwarka, and Dr. Swati Bhayana. She is also a pediatric hematology oncologist, trained, done DNB fellowship, and she is currently at Fortis, Gurgaon. So, in the interest of the time, I would not be talking about much of this, what is CBC, how it is done, what are the various cutoffs. I'd like to straight away take you to the case scenarios. अरे वो हमारे ऑडियंस भी गए पीछे है right. So okay, Dr. Amrit, the first case is for you. So we have a Ajay 4-year-old male child. He presented with multiple episodes of breath holding spell. There is history of weakness and history of pica present. Anthro-wise, the child is within normal limit. On examination, child has pallor, no hepatosplenomegaly, and rest of the examination is within normal limit. This is the CBC. How would you like to interpret it?
Yeah, so thank you so much for this case. So in the history, so we have a characteristic history that there is history of breath holding spells and history of pica. So there has been a lot of data out there and even Cochrane review which has shown that breath holding spells has been associated with iron deficiency, and once you correct the iron deficiency, 80% of the breath holding spells decrease. So whenever a child presents to you with the breath holding spells and history of pica, he definitely has iron deficiency anemia. And then other things which I would like to ask in history would be any history of transfusion, just to know
No
that
history of transfusion.
and dietary nutritional component as well. So now, going to the CBC. So first we look at the hemoglobin, TLC and platelet, just to know whether only one cell line is affected or any other cell line is affected. So in this child, HB is 5.7, the other cell lines are normal. Then we'll go towards the RBC indices. So his MCV is low, MCH is also low, and RDW is increased. So the impression is it's a microcytic hypochromic anemia with increased red cell distribution width. So we are dealing with iron deficiency anemia. So now once we have diagnosed, we should also ask whether there is any history of malabsorption or persistent diarrhea, or what is the underlying reason why the child is having.
We'll take that later. The task is CBC today. Right. Thank you. So we reached to this diagnosis with the help of Dr. Amrit, where she emphasized that the HB is low. It is microcytic hypochromic in picture. RBC counts are decreased and RDW is increased. Classical at the max, we would require a peripheral smear. Usually we do not require the iron studies upfront. Right. So Dr. Swati, the next question is for you. We have Samir, 4-year-old male child. He presented with weakness. Anthro is absolutely with the normal limit. Examination, we have pallor. There is no hepatosplenomegaly, and this is the CBC. How would you like to?
So, looking at the case first, that of a child who's 4 years with the age of tantrum, with the age of fussy eating, who's having a presentation of weakness. So he's symptomatic with that mild anemia picture. So looking at the reports, he has a mild anemia with the other cell lines being preserved, which is the first screening test we do. So mild anemia, other cell lines normal, retic count which is lowish, and the RBC count which is high. But on the background of an age of fussy eating and a background of a symptomatic child, so my differential is thiol trait, but I want to rule out a concomitant nutritional deficiency because the child is symptomatic with this mild anemic picture.
So these are the things which Dr. Swati needs to wants to highlight. The HB is low, the RBC counts are increased, MCV is low, RDW is low, Menzer index is also low, and the platelets are normal. This is another slide which helps us differentiate between, but it is only for mild anemia, not for moderate to severe anemia. When the hemoglobin is low, in the trait it is low, in the iron deficiency it could be too low. RBC counts are higher on the thalassaemic trait, whereas it is low in the iron deficiency. MCV is low in both. RDW is increased in the iron deficiency, vis-a-vis it is decreased in thiol trait. Platelets are normal to increase in iron deficiency where it is normal. And Menzer index, as I just mentioned, it is lower in thiol trait. So Dr.
Just
Amrit,
one more point
yeah,
on
please.
that.
Yeah, please.
Sorry sir to interrupt. Menzer index is increasingly used. We've been using it for ages now, and it is available at periphery also because it is MCV by RBC. But the use in a clinical practice is always questionable. We don't really know we over the front use it or not. And nowadays with the new poulters actually we use indexes as MH index or Urichigar index. So that is a very important index by which even a pathologist can actually point out that you are dealing with a sure shot case of thiol trait or you are dealing with a thiol trait with IDA.
Totally true. Totally true. So, Dr. Amrit, what are we dealing with? We have a 10-month-old male child. He is presented with anemia. There is history of 1 PRBC transfusion till date in this child. Anthro is within normal limit. On examination, there is pallor and hepatosplenomegaly, and this is the CBC.
So this is a characteristic history when a 10-month-old who has a history of transfusion, which is a significant history, and that now again he has landed up with anemia and he has organomegaly. So going ahead with the CBC, so HB is 3.6 and the TLC is a bit raised. So it looks like leukocytosis if we just go with the TLC. But now we can see that there are nucleated RBCs also which are mentioned. The platelet counts are normal. So, and when we see the RBC indices, so there is microcytosis, hypochromia present, and the RBC count is also low and RDW is high. So the impression is, so there is microcytic hypochromic anemia with increased RDW and there is a history of transfusion. And why the WBC was high? It was falsely high because of nucleated RBCs which were present in the smear. Because when a Coulter sees a CBC, so it just divides the cells into whether nucleated or non-nucleated. But whenever in the thalassemia patients, because of a lot of stress, bone marrow is under stress, so the premature precursors are released in the smear. So there are a lot of nucleated RBCs which are falsely counted as leukocytes. So that was the reason sometimes these patients are referred to us as suspected leukemia because of the leukocytosis and anemia. So in this patient, there is microcytic hypochromic anemia, RBC count is decreased, RDW is increased with nucleated RBCs. So most likely this is a case of transfusion dependent thalassemia, and then we'll confirm it with the help of HPLC.
Absolutely right. So Dr. Swati, we have a 2-year-old boy who presents with recurrent history of epistaxis, gum bleeds, petechial spots for 1 year. History of recurrent respiratory tract infection, skin infection is also present. There is a death of male sibling prior with similar history. This is the CBC.
So this becomes a very classical case of a general pediatrician practice in which we have to be very thorough with history and very thorough with examination and then jump to the reports. So I am dealing with something of a bleeding defect in the first line because there is a recurrent epistaxis. We are dealing with something which hits the Jeffrey model in our head because we have 2 of the 10 criteria present in which there is a recurrent respiratory tract infection. I'm assuming recurrent means more than 2, so fitting in my Jeffrey model. Then we have skin infections present, fitting in the immunodeficiency, clicking in my head, and a death of a male sibling. So we usually need a diagnosis of a PID in the family, but the diagnosis might not have been made and that might have led to the child being succumbed. So an immunodeficiency background with a bleeding disorder in my head hitting, and the CBC showing a mild low hemoglobin, a TLC which is okay, neutrophilic picture, and a platelet count which is very low. So again MPV which is very low. So these 2 things hitting with eczema, with thrombocytopenia hitting us to the diagnosis of Wiskott-Aldrich, and we would confirm that with a genetic test.
Absolutely. So mean platelet volume is very important. It's between 7 to 11. If it is less, there are only 2 causes in front of us. One is Wiskott-Aldrich and another is X-linked thrombocytopenia. So Dr. Amrit, we have a child who is 1.5-year-old male, predominantly milk-based diet, presented with lethargy and easy fatigability. Anthro is within normal limit. On examination has pallor, knuckle hyperpigmentation. There is no hepatosplenomegaly, and this is the CBC.
So again, this is a characteristic age, and then the dietary history, and then examination showing knuckle hyperpigmentation. So we know in our mind that we have something, it's nutritional anemia, and probably fitting into that B12 folate deficiency spectrum. So with that in my mind, we did a CBC, and then it was showing, so can you go to the previous slide? So HB is 9.9, which is low for this child, so the cutoff is 11, and WBCs are okay, platelets are okay, the DLC is okay, and the RDW is increased, and MCV is high. So it just fits into the picture. So there is anemia, which is macrocytic anemia with increased RDW. So this RDW here and also the retic is 1.25 for the HB of 9.9, which corrected retic would be less than 1%. So because of nutritional deficiency here, RDW is a very important parameter in macrocytic anemia. So if the RDW is high, it points towards the nutritional anemia. If the RDW is normal, then it will point towards the aplastic inherited bone marrow failure syndromes or the other causes of macrocytic anemia. And also retic being low, it tells us that there is some deficiency, that is why the bone marrow is not able to produce hemoglobin, the RBC cell. And now based on this, in the iron deficiency anemia, it's okay to just go with the CBC and smear. So in this also, we'll go for a smear. We can see hyperpigmented neutrophils, and because the DNA maturation is delayed as compared to the cytoplasmic maturation, and sometimes these patients can also have leukopenia and thrombocytopenia. And but in case of iron deficiency anemia, it's not imperative to do the iron studies in all the patients. You can just do a CBC and smear, and based on the response to therapy, the diagnosis can be made. But in these patients, it's better to do B12 and folate levels.
Absolutely right.
In case B12 folate levels are normal also, because sometimes they can come as normal because the sensitivity is low. Because of the alteration in diet, the levels can come as normal. So in those cases, we can even do homocysteine levels and methylmalonic acid levels just to make a diagnosis.
Absolutely right. So, Dr. Swati, we have a case for you. We have a 7-year-old male child. There is progressive pallor for 12 months. There is history of 3 PRBCs transfusions till date, 3 episodes of epistaxis, no fever, skin rash, jaundice or recurrent infections. Birth history was absolutely normal. Family is not significant. Anthro is within normal limit. There is on examination pallor, no stigmata of inherited bone marrow failure syndrome, no hepatosplenomegaly, and this is the CBC.
So when we see an age of a 7-year-old child who does not have any antecedent or any precipitating factor, but has a long history of repeated repeated transfusions and repeated 2 cell lines being affected, so we want to definitely do a screening CBC in them. The clinical examination supports that we might be dealing with what is known as the idiopathic cause of this precipitation. Now coming to the CBC, we have a very severe anemia. The WBC cell line is reduced. The neutrophils are also reduced. The absolute neutrophilic count, which is a very important parameter in the DLC, is reduced. The platelets are reduced, and the retic is also 20,000 absolute. We have a MCV which is on the higher side, which is supporting our thinking of aplasia happening all throughout. And we have a B12 which is okayish, and a folic acid also which is okayish. So we have a peripheral smear. Whenever we are dealing with a pancytopenia picture, we always have to look for a peripheral smear, not having any abnormal cells. Because a pancytopenia can be a very commonly presentation of leukemia. So first, in a peripheral blood, always rule out abnormal cells. Then in peripheral blood, rule out that a picture of a aplasia is present. And the picture of aplasia has to be confirmed with the bone marrow, because you may be dealing with the aleukemic leukemia as well.
So here is your bone marrow.
So the bone marrow is showing markedly hypocellular, I am assuming, and a very important point, we have to take a very good biopsy piece whenever we are dealing with the aplasia picture, at least a 2 centimeter piece. The myeloid to erythroid ratio is okay, there are no blasts, and here we are confirming the diagnosis of a gross aplasia happening, and cellularity less than 25%, confirming our diagnosis of aplastic anemia with no precipitating factor present, with no stigmata present. I am assuming I am dealing with the idiopathic picture, but again would like to confirm with the whole exome test.
Here is your whole exome. It's absolutely
So
normal.
whole exome is normal, so I am dealing with the idiopathic aplastic
Absolutely
anemia.
right. So there are few definitions. If you can just tell something about this for the.
So whenever we are having an aplastic anemia, we always, in a layman, we always say that the factory is defective. Whenever the factory is defective, everything coming out of the factory is low. Your all cell lines are affected. So we have kept a usual cutoff of a hemoglobin of less than 10, a platelet count of less than 50,000, neutrophil picture of less than 1500, which defines mild neutropenia, but usually have a severe neutropenia which is less than 500, or a very severe neutropenia which is less than 200. They have also kept a cutoff of retic count, in which we have a absolute retic cutoffs, which we get different answer. At times it is at times 20,000, in some places it is 50,000, but we try to fit them in a modified Cometa criteria, and we label them as a non-severe or a severe form and then take it forward from there.
Absolutely. So this is the algorithm for aplastic. The first choice is match sibling donor transplant. Second choice is between immune suppressive therapy and matched unrelated donor. So the choice, if it's a well thriving center, definitely the transplant would be answer. But if it's like a non-thriving center like ours, the ATG is the answer. So we are doing giving ATG, immune suppressive therapy. So if any patient who needs free of cost ATG, please refer to us. If they have money, refer to them at Max and Fortis. So third is the mismatch unrelated donor, and then of course the second course of ATG, androgens, L-Trubabag, and LM2zumab are the other options. So just a brief word about this immune suppressive therapy. So this ATG is given at the rate of 40 milligram per kg per day for 4 days, consecutive 4 days. And methylpred is just to prevent serum sickness. Thereafter, oral pred is also given for 2 weeks just to prevent the serum sickness, and thereafter the cyclosporin is added. So we continue giving cyclosporin. The study says if the response is not there after 3 to 6 months, we should opt for the second line. But resource constraint settings, we continue, and we have seen response up to 18 months also. So that's it. So my messages are CBC is very important. History is also very important. So it provides valuable information and it can narrow down diagnosis and can identify the subtle abnormalities that may direct to additional diagnostic studies. Thank you very much.
Thank you so much.
Ajay, Manish. Please.
Criminal to not do a CBC, sir. It is criminal to start iron therapy on history, but it is not criminal to not do iron studies. So because it's a very grey zone of presentation in which the child presents. Not every child with iron deficiency sitting in a private setting has pica. Not every child with iron deficiency has a very long history. So as she is pointing, one thing is correct, that if you have a very classical thing coming up, कि pica hai, food fattiness hai, everything is fitting, then okay, we may consider starting. If just like everything is not very classical, then CBC and iron study should be done, because we are sitting in 2025 and everybody is coming with a chat GPT.
So that is for the Fortis people, but the guidelines are very clear what Dr. Amrit said. CBC with the PS is sufficient. Iron studies are only merited when we are suspecting something different or the response to iron therapy is not to the mark which we expect. The up to the mark is if the rise in HV is not more than 1 gram percentage after 4 weeks of therapy. So these are the guidelines, but yes, resource-rich settings like yours definitely should. Ideally, it should be done, but not. Guidelines definitely says iron studies upfront are not needed. They are needed if we are suspecting a different diagnosis or the response is not to the level which we expect. It's like this.
Thank you, Dr. Mukesh. Thank you.
Thank you so
Thank
much.
you.
Thank you so much.
Okay. Thank you.